for inviting me here. I am Dr. Iracon from City of Joy. Before going to the details of the adult vaccination, we should know the basics of vaccination. Vaccines, the suspension of live or killed microorganism or antigenic portion of those agents presented to a potential host to induce immunity to prevent that specific disease caused by that organism. There are different types of vaccine. Live attenuated vaccine, where the vaccine lose their capacity to cause disease but retain the ability to induce antibody response. Inactivated vaccines, where the organisms have been killed but they can induce the antibody response. The difference between these two live attenuated vaccines should be given in caution in a severely immunocompromised patient, where the killed vaccine can be given in an immunocompromised patient. There are cellular fraction vaccine, recombinant vaccine like the hepatitis B and recombinant zoster vaccine, antitoxins and toxins. Now, a vaccine must produce a protective immunity with only minimal side effects, and it should be immunogenic enough to produce a strong and measurable immune response. The immunization in patients with autoimmune inflammatory rheumatic disease is must because the patients are more prone for infection due to the disease process and due to the drugs which is used to treat the disease. And the vaccination is an attractive method of preventive infection, but the efficacy of the vaccine will be reduced and there may be risks due to vaccination, especially for those who are receiving live attenuated vaccines. There are multiple drugs, I am not going into the details. They are producing immunosuppression, either acting on T or B cells. This slide is very important. For most patients with AIRD, using conventional synthetic disease-modifying antirheumatic drug, most biologics or glucocorticoids, vaccinations are expected to confer adequate protection, although the immune response to some vaccine may be blunted. The degree to which the immune response may be altered by these modification medicines varies based on the specific immunosuppressive drug regimen, vaccine is used, and the other patient-specific factors. What is the timing of the vaccine administration? If possible, vaccine should be given before starting the immunosuppressive therapy. If it is an inactivated vaccine, it should be given just prior to start of the immunosuppressive therapy. This increases the likelihood of developing a protective immune response, particularly if the patient is getting the rituximab. The vaccination prior to immunosuppressive therapy also allows us for administering any of the needed live vaccines, those who are generally contraindicated while the patient is on immunosuppression. Now, the patient who have not been adequately vaccinated before the start of immunosuppressive therapy, we can give any necessary inactivated vaccine as soon as possible, but ideally, this is very important, during the period when the immunosuppression is low. For the patient with rituximab, vaccination should be given at least 3, preferably 6 months after the last dose of rituximab. For live attenuated vaccine should be given before starting immunosuppression. Now, after this, I will go to the international guidelines about the vaccination in adult patients. I will go for general vaccination as well as the COVID vaccination. First I will go EULAR, updated statement 2019, then APLAR, consensus statement, and ASIA 2022 guideline. The EULAR again emphasizes the need of vaccination in a patient of AIRD, and they told that adult vaccination will potentially translate into a lower rate of hospital admission due to infection, emergency room visit, and the rate of invasive infectious disease. That is the most important, invasive infectious disease. There are a lot of AIRD. What is the overarching principle of the EULAR? This is 2019 update. Vaccination in patients with ARD should preferably be administered during quotient disease. Vaccines should preferably be administered prior to planned immunosuppression. Non-live vaccines can be administered with patients with ARD while treated with systemic glucocorticoids and DMARDs. The recommendations, there are 9 recommendations given by EULAR in 2019. Recommendation 1, as you all know, influenza vaccine should strongly be considered for majority of patients of ARD, and adverse events of influenza vaccination in patients of ARD seem comparable to those with healthy adults. Pneumococcal vaccination should strongly be considered, but the stepwise pneumococcal vaccine, as you all know, we have pneumococcal conjugate vaccine 13. We should give conjugate vaccine. After 8 weeks, we should give PPSV. But this is in the year 2019 when the PCV20 was not available in US. Now in US, as PCV20 is available, only single shot of PCV20 is sufficient enough to produce the immunity. Recommendation number 3, patients with ARD should receive tetanus toxoid and passive immunization if required. Hepatitis A and B should be given in a patient who are at risk. This is the most important recommendation given in the year 2019. Why I am telling that herpes zoster vaccination may be considered in a high-risk patient with ARD. We know that patients who are suffering from lupus and myositis are more prone to develop herpes zoster. And at that time, only Zostavax was available, which is live attenuated vaccine. Now, with the advent of the recombinant zoster vaccine, this is not very true. This was this guideline in the 2019. So, this Zostavax, that time, these vaccines preferably administered 4 weeks prior to the initiation of the biological DMARDs or target-specific DMARDs, but not during the treatment of biological DMARDs or target-specific DMARDs. But it can be given the patient on methotrexate. Now, yellow fever, again, it's a live attenuated vaccine, better to be avoided. HPV vaccine to be given as per normal schedule. And this is also new addition from 2016 that immunocompetent household members of patients with ARD should be encouraged to receive vaccine according to the national guideline with the exception of the oral polio vaccine. So much so that highly immunocompromised patients should avoid handling diapers of the infants vaccinated against rotavirus for at least 4 weeks following the administration of the vaccine. And number 9 recommendation, live attenuated vaccine should be avoided during the first 6 months of life in newborns of mothers treated with biologics during the second half of the pregnancy. This is all about the EULAR 2019 guideline, then come the COVID era. So we got the EULAR recommendation for the management and the vaccination of the patient of RMD in the context of SARS-CoV-2. It was published in the last year, November only. The overarching principle of EULAR is that, in general, patients with RMD do not face higher risk of contracting SARS-CoV-2 than individuals without RMD and do not have a worse prognosis when they contract it. This is a very bold overarching principle by EULAR in the month of November last year. And this should be treated by the team of doctors who should include a rheumatologist. There are 9 recommendations by the EULAR regarding SARS-CoV-2. Number 1, as you all know, patients with RMD should be strongly advised to comply with all infection prevention and control measures prescribed by public health authorities before and after SARS-CoV-2 vaccination. Patients with RMD should be advised to receive SARS-CoV-2 vaccination with any of the vaccines approved in the country. Third is very important. Patients with RMD who have been vaccinated against SARS-CoV-2 should be advised to continue their treatment unchanged. Those who have not vaccinated should be advised to continue their treatment again, taking into account that certain therapies have been associated with an increased risk of severe COVID-19. So, EULAR do not recommend stoppage of RMD treatment while during the COVID-19 era. In the patient of RMD receiving long-term glucocorticoids, develop suspected or confirmed COVID-19, glucocorticoids should be continued. In a patient of RMD receiving rituximab treatment, SARS-CoV-2, postpone the next cycle of rituximab. Patient with RMD with initially mild symptoms experiencing worsening of the COVID-19 symptoms should immediately seek further healthcare advice. And the patient of RMD should be advised to update their general vaccination status. This is also very important. During the COVID time, the vaccination status of the general population should be updated, particularly for pneumonia and influenza. And the patients of RMD not using immunomodulatory treatment, SARS-CoV-2 vaccination should precede a treatment start and with such therapy if clinically possible. So first you give COVID-19 vaccine, then wait for 2 weeks, then you give the immunosuppressive treatment. And the patient with RMD using rituximab, SARS-CoV-2 vaccination should be scheduled in a way to optimize vaccine immunogenicity. Now, after this EULAR COVID guideline, I'll briefly touch upon the consensus statement from our Asia Pacific League Against Rheumatism on care for patients with rheumatic disease during COVID-19 pandemic. And there were 25 consensus statements, but I will highlight only 4 consensus statements, which is slightly different from that of EULAR. Number 1, this is the APLAR consensus statement number 1. Patient with immune-mediated RMD may be at a higher risk of COVID-19 and of respiratory failure than that of general population. But the grade of evidence is low. Clinical manifestation, this is the consensus 15, manifestation mimicking RMD, lab reports of positive ANA and APLA have been reported with COVID-19 patients. These patients should be followed for the possibility of persistent intermediate to long-term immune dysregulation. In general, RMD treatment may be reintroduced at least 2 weeks after recovery from acute COVID-19, but they need to be individualized based on clinical scenario and the patient judgment. But the grade of evidence is low. For asymptomatic individual, RMD treatment may be reintroduced approximately 10 days. If the patient is symptomatic, wait for 14 days. Patient is asymptomatic, wait for 10 days. And this is by Professor Malvia. This is, I am not going into the details of that. In 2017, it came, the practical guide to adult vaccination for patients with autoimmune inflammatory disease in India. Now, COVID-19 vaccination in ARD, a multi-center survey from southern India, it came this year only. It emphasizes that immunosuppressed patient tolerated the vaccine without any major vaccine-related side effect. Now, I am coming to the last ACR 2022 guideline. I will highlight only those 3-4 points which are new. Number 1, for RMD patient aged more than 65 years and the RMD patient between 18 to 65 years who are on immunosuppressive medication, we should give adjuvanted influenza vaccination rather than normal influenza vaccination. But unfortunately, adjuvanted influenza vaccination is not readily available in India till now. For patients with RMD, more than 18 years who are on immunosuppressive medication, administer the recombinant zoster vaccine is strongly recommended. I am telling, in US, Zostavax is not now available. It is replaced by recombinant zoster vaccine from 2021 onward. So they are only giving this vaccine, recombinant zoster vaccine, at an interval of sorry, I'll take another just 2 minutes. We can give multiple vaccines in the same day, and the medication management, that is by SCR, at the time of non-live attenuated vaccine administration. If possible, you hold methotrexate for 2 weeks after giving influenza or pneumonia vaccine, if possible. That will increase the immunogenicity of the methotrexate, of the influenza vaccination. Now, if the patient is on glucocorticoids, try to lower the glucocorticoid dose less than 20 milligram a day. That will increase the immunogenicity of the vaccine. For RMD patient, holding immunosuppressive medication for an appropriate period before and 4 weeks after live attenuated virus vaccination is conditionally recommended by ACR 2022. This is true for all immunomodulator except JAK inhibitors and rituximab. In JAK inhibitor, it is only 1 week you have to hold before live attenuated vaccine administration, and in rituximab at least 6 months. So, to summarize, the patient with ARD have an increased burden of infection. So, the prevention is crucial in the management of patient of ARD. We should first take the detailed vaccine history. If possible, vaccinate the patient in a quiescent phase against influenza, pneumonia, tetanus toxoid, hepatitis A, B, human papilloma vaccine, and herpes zoster vaccine as per recommendation EULAR guideline 2019 and COVID-19 vaccination as recommended by different guidelines. With this, thank you.
Thank you, Dr. Narayan Banerjee, for a very comprehensive
vaccination against pneumonia or influenza, which I think both of them are absolute must before you start the treatment. And the schedule of pneumococcal vaccine is very important to understand, but here I cannot, but if somebody wants to know, they can read my paper. I have given the exact timings and when to give it and when not to give it. Those details are there. But just remember that otherwise in a healthy person, pneumococcal vaccine is not given till the age of 60. You always give it beyond that. Although the things are changing now, even in pediatric age, they are giving pneumonia vaccination. But in rheumatological conditions, systemic immunoinflammatory diseases, vaccination with pneumonia, both the conjugate and the polysaccharide vaccine are necessary. Remember, one of them is T-cell vaccine, and therefore it's never to be repeated, while the other one is a B-cell vaccine, needs to be repeated every 5 years with a maximum of 3 doses in the lifetime. This schedule, how to coordinate with the age of the patient, 65 beyond and before, that's a bit complicated, and that can be at the individual level only. I will like you to also understand a very important thing. We discussed methotrexate, and I kept on saying that it is not immunosuppressive. And here you have the evidence that it's really bringing down the antibody formation. There are always an exception to a rule. Methotrexate's action on pneumococcal vaccine is an exception. Methotrexate otherwise does not cause much immunosuppression. In fact, the EULAR committee has divided immunomodulating drugs into 2 categories, immunosuppressive and immunomodulator. While azathioprine is immunosuppressive, methotrexate is immunomodulator, while cyclophosphamide is immunosuppressive, meflunomide is a immunomodulator. So that scheme is available. I have given a talk, I have recorded it in case you need. The list of drugs that are immunomodulatory is different than drugs that are immunosuppressive. So with one single brush you are painting all what we are using immunosuppressive, that's wrong. Some of the biologicals, definitely they are immunosuppressive. At the top is rituximab. Therefore, if you have a patient on rituximab, you will have to hold it till the vaccine schedule has been completed. Only then you restart rituximab. Even TNF inhibitors really don't suppress the immune response against vaccines to any large extent. But remember, even senior rheumatologists are forgetting that every patient above 18, because we are adult rheumatologists, I'm sure in pediatric must be the same, but at least 18 and above, every patient must be given complete pneumococcal protection and complete influenza protection. And influenza, depending upon the latitude, below Himalayas and above Bangalore, is end of June or July, while beyond the Himalaya basin, Himalaya foothills, north of that and south of Bangalore, it is September when you give influenza vaccine. These are the timings that you have to remember. Tell the patient, and my patient on the other hand now, Dr. Sahab, you have not written influenza vaccine. हमने कहा, but I told you. हाँ, मैंने ले लिया सर, आपने नहीं कहा तभी भी ले लिया. So remember, make the patient ask हमको vaccine क्यों नहीं लगा, rather than you telling them take the vaccine. That is the stage we all should be. Thank you.
Thanks, Dr. Marge, for the comment. Dr. Banerjee, do you get the kill zoster vaccine? Are your patients in India?
I was in the meeting when the Zostavax was introduced in India, but unfortunately, due to the cost factor, it has been withdrawn. Costing around 6,000 rupees, so very few people are getting that Zostavax. And nowadays, US is also not recommending Zostavax. They have other vaccines.
Syngenix is one. But Syngenix is not
available in India. So, do you give human papillomavirus to your patient children with or young adults?
That is must.
So you have been giving papillomavirus below 24, whether male or female.
That has been changed actually. If you see the ACIP guideline in 2022, it has increased to 45 years.
45 years. So
you can give HPV.
Dr. You had mentioned that you withhold methotrexate for 2 weeks after the vaccination dose for an optimum antibody response. Mycophenolate also you withhold for 1 week, is it?
I am telling the only drug you can give is methotrexate.
Yeah,
That's why
2 weeks post.
That's why I am telling that was the Euler guideline regarding the herpes zoster. When only the live attenuated vaccine was there, they were telling you can give methotrexate. But don't give toxicity because at that time toxicity came. Widely used, I think. But
so the recommendation is 1 week for MMF and 2 weeks for methotrexate.
yes.
Post vaccination.
Yes.
So one more, have you come across cases? One of the fears when you give TNFIs for pregnant women, particularly beyond 32 weeks, is the BCG vaccine causing disseminated tuberculosis to the child. And one way to overcome it is giving certolizumab, which doesn't cause the blood barrier.
That's true. That's why that's what the recommendation number 8. You cannot recommendation number 9 by Euler. You cannot use live attenuated vaccine.
So thanks very much, Dr. Banerjee. We are running out of time. Thanks for your
Thank you.
I have a very short comment.
yes, ma'am.
We had actually tough time with the rheumatic patients who were on methotrexate. So when to give them COVID vaccine, the booster doses and all, and influenza vaccine also. So for the influenza vaccine also we have to withhold for 2 weeks. Then again for COVID vaccine we have to withhold for 2 weeks. So sir, what comment do you have on this?
You can give simultaneously 2 vaccines, but national guideline is totally different.
Yes.
In India, Indian government has told that you have to give 2 weeks gap. So you can't.
But I think internationally you can give it simultaneously.
But in India, the national guideline is separate.
And the patients usually don't like to take both the vaccines.
But you give influenza pneumonia at single time. You give one
Not
PCV13.
influenza and pneumonia.
I'm telling
Influenza and
you.
COVID.
But that's it. But international guideline is different and Indian government guideline is different. So I cannot go beyond the government guidelines.
I think it's not updated. Previous recommendation even internationally was to have a gap, but then internationally it got updated. But our Indian guidelines have not been updated on that one particular point. But I think we have been giving simultaneously COVID and influenza vaccine.
Thank you.
So after that, I think we'll have a.
The crowd, I should tell you that it's a very basic talk that I prepared because the target audience is general practitioners. So I'm sure my rheumatology colleagues may find it a little too very simple. It's the rational use of steroids in rheumatology. We all know about the fight or flight reaction, where whenever you see something, you either go and face it headlong or you run away. That's where the steroids come into action in the human body. So when we talk about the steroids, it's either the mineralocorticoids, the glucocorticoids, or the androgen precursors. These are the group of drugs that are included under this category pharmacologically. But when we talk about steroids in rheumatology, it's mostly about the glucocorticoids that we refer to. A little bit about the basics of the steroids. We know about the hypothalamus-pituitary adrenal axis. The whole secretion of steroids in the body is governed by the hypothalamus, where we have the corticotropin releasing hormone, which acts on the anterior pituitary. Then we have ACTH acting on the adrenal gland and the secretion of the steroids, which again are governed by the diurnal rhythm of basic secretion of hormones, which is an effect of the daylight and our activity, our sleep-wake rhythm. Then we have the negative feedback regulation of adrenal steroids, especially when there is a higher level of steroid in the circulation, there is a negative feedback. So the secretion goes down and there is a marked increase in steroidogenesis in response to in stress. That's very important. So that's how, psychological factors also come into play when we talk about steroids. So here are a few lines about steroids and low mood. The hypothalamus-pituitary adrenal axis is altered in major depressive disorders and in stress and mood disorders. Hence the concept of the use of CRH antagonist in anxiety and mood disorders. This, I think, pretty much explains the low mood or depression that gets surfaced in people who have been on long-term use of steroids for the chronic inflammatory conditions that we handle in rheumatology. Now, why do we use steroids in treatment? It's basically to combat shock of any kind. We can use steroids. We use steroids to control inflammation, especially the inflammation that we encounter because of the immunological reaction that falls out in rheumatological diseases, to control anaphylaxis, in adrenal insufficiency. There, of course, we have to also use the mineralocorticoids, and in autonomic disturbances. These are the conditions where in medical practice we have to use steroids. Now, coming to rheumatology. That was the bigger platform. Now this is confined to rheumatology. The prime idea in rheumatology is to control the inflammation ever since it was introduced in the 1950s. But efforts to minimize the target or the adverse effects by also reaching the target of reducing inflammation, or a balance between the therapeutic effect and the adverse effects, is the challenge that we have to face while we are using these drugs. Now, the effect of corticosteroids on the immune system, what does it do? It causes activation of the immune system. It causes inhibition of the activation of the immune system, inhibits the proliferation of the cells into the cells that will kind of proliferate and continue the inflammation. It prevents the differentiation of these cells so that the inflammation is arrested, and it also causes inhibition of the survival of the inflammatory cells. So downstream, inflammation is going to be controlled by steroids. A little into the common diagram, that the flowchart that we all know about, the glucocorticoids, where they act has been highlighted. Basically, the wide range of cytokines that are secreted, like IL-1, IL-2, IL-3, 6, 17, TNF-alpha, interferon gamma, GM-CSF, all this can be inhibited by steroids. So in turn, what happens, these are responsible for the synovial proliferation, bone destruction, cartilage damage, which are the things that occur in a rheumatological disorder. So all these pro-inflammatory enzymes are also inhibited. The development of prostaglandin and leukotrienes and the important mediators of the inflammatory cascade are inhibited. There is inhibition of the development of COX-2, phospholipase A2. So as a result of all this, what's going to happen? The chronic inflammatory process that's going on in the body in these rheumatological diseases will be controlled. Now, when we are using steroids, what is most important to know that the dose of steroid is very important in telling us what are the side effects that you can expect. If we use a low dose, which is usually less than 7.5 milligram of prednisolone, the side effects are much less. Medium dose is 7.5 to less than 30 milligram prednisolone per day. High dose is 30 to 100 milligram prednisolone per day. Very high dose is more than 100 milligram of prednisolone equivalent per day. And pulse therapy, as we know, is more than 250 milligram of prednisolone equivalent per day. Now, after looking at all this, you can almost pretty much feel that yes, glucocorticoids are the drugs that can control all the inflammation that occurs in rheumatological diseases. But yet, we are scared. Why? Because of the battery of adverse effects of the glucocorticoids. The risk of infections being number one. The bactericidal and fungicidal activity in the body is decreased by the use of long-term steroids, especially with high dose. So if the dose is less, the chart which I have just shown, we reduce the chances of infection. I've shown the lung picture because lung infection is one of the commonest. The infection could be anywhere in the body. Then we know about the cardiovascular adverse side effects. It causes edema, weight gain, high blood pressure, cardiac complications, it causes the metabolic syndrome, and it can cause new onset of diabetes in people who are not diabetic, and in people who are already diabetic, it could worsen the symptoms. So glucocorticoids have a harmful effect on lipid metabolism, glucose metabolism, insulin resistance, blood pressure, and obesity. Osteoporosis, this has already been discussed. This is a major side effect of long-term use of steroids. High dose of steroids stimulate the Rankel synthesis by the osteoblast precursors, and this activates osteoclastic differentiation and bone resorption. Basically, the osteoclastic activity increases in the bone, so there is destruction of bone. To prevent this, we should maintain a good calcium level and a good vitamin D supplementation to, as far as possible, combat this side effect and also use the minimum possible dose of corticosteroids. Another important thing is aseptic osteonecrosis. This again is seen with high dose of steroids. It's rarely seen in treatment with prednisolone dose of less than 20 milligram per day, but can happen where there is basically infarction, there is occlusion of the blood vessels, and there is aseptic necrosis of the femoral head. Myopathy is a clinically evident in patients who have been on long-term use of steroid, but here the dicey question is, in inflammatory myopathies, steroids are the anchor drug. If you use steroids in inflammatory myopathies, the person will respond. And in steroids used for long causes myopathy. So there is a difference because in inflammatory myopathies, you have the rising muscle enzymes, you'll have pain and tenderness besides the weakness. But in the myopathy that is induced by steroids, you have only the proximal muscle weakness. Gastrointestinal side effects are more when steroids are used with NSAIDs, which has already been discussed in one of the previous talks. Endocrine and metabolic side effects, this is very important. Adrenal insufficiency may come up because of long-term use of steroids, higher doses, multiple dosing, so we use one single dose in the morning. New onset of diabetes can occur because of the effects on the endocrine system, which has been illustrated. Lipolysis and increased amount of free fatty acids and redistribution of adipose tissue are characteristic, and so we have the typical lemon and matchstick appearance of patients on long-term use of steroids. Then we have the ocular adverse side effects on the eye, posterior capsular cataract. Genetically predisposed people, besides cataract, can develop glaucoma. So glaucoma is a little less common, but it can occur because of long-term use of steroids. Then cutaneous adverse effects. This is the typical picture that has been illustrated here. Bruises and skin atrophy occur due to accelerated protein catabolism, facial erythema, hair fragility, acne, hirsutism. This is typical that you can actually make out when a person is on long-term use of steroids. Neuropsychiatric adverse side effects are, of course, anxiety, depression, psychosis, delirium, confusion. We typically describe as steroid effect on the nervous system. But now, what is the role of steroid in rheumatology? These are the definite areas where we use steroids in rheumatology. One, in rheumatoid arthritis. When do we use steroid? We use steroid in the lowest possible dose when there is a flare of the disease. In the meantime, we start the DMARDs, and as the DMARDs take over, we taper down the steroids and take it to the minimum possible dose. Similar it is in SLE flares. When a person comes in a flare, we have to use high doses of steroids and, of course, start with immunosuppression. IVIG may be followed up with immunosuppression, and as it takes over, we again taper down to the lowest possible dose to keep the patient in remission. Similarly, in polymyalgia rheumatica, steroids have to be used. In vasculitis, steroids are life-saving drugs. In inflammatory myopathies, which I just mentioned, that inflammatory myopathies, you have to use steroids to control the initial inflammation, but steroids used for long causes myopathy. So we should be able to distinguish between the myopathy caused by disease per se and that caused by drug. It is the muscle enzymes and the pain that actually differentiates between the two. This is what I just said. In rheumatoid arthritis, the use of steroids should be confined to controlling flares, initiate methotrexate together with steroids, and gradually lower the steroid to the lowest possible dose. In SLE, which is a multisystem disease, we treat with hydroxychloroquine and immunosuppression with cyclophosphamide, mycophenolate, tacrolimus, or azathioprine, and in crucial situation, we have to use steroids. A few words about scleroderma. In scleroderma, steroids have a controversial role because steroids can precipitate scleroderma renal crisis. So here, one of the important points to remember is once skin tightening has occurred or irreversible skin damage has occurred, there is very little that steroids can do about the disease. So in scleroderma, we have to use it with caution in the early stages of the disease. So this is something I have already mentioned about the inflammatory myopathies and how we distinguish it from disease and from steroid-induced. In vasculitis, it's very important. Steroids are the life-saving drug. The other route of administration of steroids is intraarticular. If a disease goes into remission, all the joints have become quiet, one joint is in a flare, we use intra-articular steroids, but be careful about infection, steroid arthropathy, bleeding, sometimes injury, and tendon rupture. So in conclusion, we can say that steroids are a very important armamentarium in the treatment of rheumatological diseases, but we have to be aware of all the side effects and be conscious about the dose we are using, bring the disease into remission, maintain the patient in remission with the least possible dose and the specific drugs per se. Thank you.
Thanks, Dr. Madhumita, for that brilliant talk. Very comprehensive and precise timing. Is there any questions from the audience? Yes.
How many
Can you
milligram?
identify yourself and then, if you don't mind.
I'm Dr. Iracon from Tamil Nadu, sir. MD Can. How many milligram of prednisolone given for how many days can be stopped abruptly without any need to taper?
If you're using a very minimal dose of steroids, it's on? Okay. If you're using a very minimal dose of steroids, less than 10 milligram, there is no need to taper. But if you're using a higher dose, 30, 40 milligrams, yes, and you're using it for a longer period of time, you have to taper down before you stop. Maybe sir is going to add something.
10 milligram for how many days? More than 7 days we need to taper or?
This month's Arthritis and Rheumatism has a paper on the controversy of continuation of glucocorticoid in rheumatoid arthritis. It says age-wise, Above 60, it is very useful to give. A small dose which should be less than 7.5. Now this is exactly the opposite of what the gut feeling is. The elderly age you give, they will develop osteoporosis and other side effects. But the paper has shown very clearly that even a residual amount of inflammation going for a long period of time is much more toxic to the blood vessels and heart attack and cerebrovascular accidents than a small dose of corticosteroids, and therefore on balance, above 60, a small dose can be given, and that adds up to a betterment of inflammation, which will then protect the heart also. But in young age, as far as possible, don't give it over a short period of time after the bridging therapy.
Gloria study. That's a Gloria study.
Yeah. Yeah, right.
Gloria.
I'd just like to add that in my practice, I usually avoid oral steroids, injectable steroids, and if a patient comes with lots of inflammation in the joints, I give intra-articular and start on methotrexate and other immunomodifying drugs. And by the time the drug takes effect, the intra-articular injections still have effect. So when this wears off, that one comes up, and there is no need to give any oral steroids on a regular basis.
Rajamani sir.
And I've been doing this for the last 30 years. It's working again.
Rajamani sir.
I'm a clinician, and I am very pleased to hear what Professor Malavi just said. When you have somebody who's above the age of 70, I'm sure many of you would not like to give a non-steroid to them because you want to control inflammation or pain or whatever because of the risk of GI and particularly the kidneys. And I tend to use a very low dose, 2.5, and believe me, although many people may think it's a placebo, it works. And I feel that this recent comment from Professor Malavia that 2.5 milligram of steroid is much, much better than going ahead and giving your non-steroidals to anybody above 70, be it for rheumatoid or even be it for asthma. Although many may consider that as a tiny dose, it works. And believe me, it works. And one other point is steroids have also been considered as a disease-modifying drug in rheumatoid arthritis.
I think steroid is a magic drug and it's a two-edged weapon. If you look at the profile of rheumatic disorders, in rheumatoid arthritis comparatively less amount of dose is required in comparison to that of SLE. Because in rheumatoid, it's anti-inflammatory effect. In SLE, it has got immunosuppressive effect, and also in case of vasculitis. So potential risk of side effects depend upon the quality of the patient or nature of the patient. And so obviously we have to be careful about the distribution of dose of steroids in different states of rheumatic muscular diseases. That's why you get, and steroid has got both genomic action and steroid has got non-genomic action. And because of the non-genomic action, it acts well in case of SLE crisis. And genomic action, it acts, control the phagocytosis, stabilizes lysosome and opsonization. Because of this differential mechanism, steroid has got a different type of effects. But on the other hand, it has got innumerable number of side effects, more often seen in case of lupus and vasculitis than in case of rheumatoid arthritis.
Of course, you always come across situations where you have active flare of lupus like a major organ involvement, along with an infection and maybe, God forbid, a disseminated TB. So you have to, it's a very dicey situation to use the steroid in the right time.
In those kind of situations, as we always say, it's a
general practitioner focuses on overall health. In fact, the GP is the one who actually is a backbone for the community health in our country. They serve an important role in a much wider healthcare system. The general practitioner's duties as a primary caregiver are broad. And some examples of the care they provide include immunizations, physical examination, mental health checkups, relevant investigations, chronic or long-term illness care, references to specialists, and follow-up care. Of course, some of them specialize in referrals to specialists, but the curriculum should be constantly updated to align with the latest medical advancements, research, public health concerns. Biologics are the latest addition in the treatment of certain rheumatological disorders. So what are the biologicals? All of you know that, but I'm just again stressing again. And which rheumatological disorders may need them? There are several inflammatory arthritis or autoimmune disorders which may warrant at some point of time the usage of biologics. And you have the psoriasis behind the pinna, and it can be in any areas like navel or gluteal regions. Spondyloarthritis, ankylosing spondylitis, it does affect the women as well. The polyarticular gout, which may mimic rheumatoid arthritis to begin with, but this 45-year-old male, the toughest can be seen over the base of right great toe. In fact, he had the involvement of hands as well. Systemic lupus erythematosus, the connective tissue diseases, especially with a malar rash, developing a gangrene of toes. He may also be having the nephritis or vasculitis. Systemic sclerosis with the scleroderma, hide-bone skin with salt and pepper pigmentation, digital pits, ulcers. They may have renal crisis. I'm just showing them that these patients may need, and they have to be very carefully assessed whenever they time patients. So aim of the management is to improve the quality of life by ensuring the patients having the appropriate treatment to reduce the disease progression with improvement in signs and symptoms. So what happens if we do not treat or treat suboptimally? Our Bible of Rheumatology, one of the one, Kelly's textbook of rheumatology shows this way back when there is no appropriate treatment available. We do see similar patients, but fortunately with advanced therapy, we do not encounter such advanced patients, let us say rheumatoid arthritis or any other autoimmune diseases. So if you take rheumatoid arthritis as a prototype, the importance of early aggressive treatment stands out. We can differentiate as early disease or disease onset, established or end stage. The early disease is the one which actually yes. This is the one where we have to probably put our treatment. So consequences of RA all are known, they were already mentioned. The less function, quality of life decreased, work disability increased, life expectancy 1 to 2 decades before they die. So when to refer to rheumatologist? Suspected persistent synovitis, increased acute phase reactants, higher titers of rheumatoid factors or ACPA, involvement of the multiple joints, especially small joints, symptom onset more than 3 months, presence of systemic features like fever and fatigue, and suspicion of any internal organ involvement. These are nice guidelines, National Institute for Health and Health Care Excellence from UK. So what GPs can do? Improve understanding of the condition and management, explain the risks and benefits of the investigation, explain the importance of specialist care. GP can carry out blood tests including rheumatoid factor. They will be done anyway in the rheumatologist. Request for X-ray hands, feet to look for the soft tissue swelling and erosions. So goals of the treatment, clinical outcomes, remission or disease activity, then radiographic outcomes, inhibit the joint damage, functional outcomes, quality of life improved, or activities of daily life are improved. The NSAIDs, steroids, imaging, laboratory, they are all informed in the morning itself, very well projected. The disease-modifying anti-rheumatoid drugs can be classified as synthetic or biologic, and my talk is on biologics now. And there are bio-originated DMARDs or biosimilar DMARDs. And we have plenty of biosimilars available but lesser cost. Conventional DMARDs, again was mentioned very nicely by research in the morning. Target to treat strategy. Methotrexate is of course the anchor drug. Hydroxychloroquine, milder palindromic arthritis. And short-term bridging of the steroids was again well mentioned. Conventional DMARDs to be started within 3 months, actually as early as possible. Combination therapy was also explained, and consider NSAIDs or PPA only to bridge the therapy in initial as an anti-inflammatory. But conventional DMARDs are a lot of unmet needs. They may fail to prevent long-term damage. They do not induce clinical remission generally. Low compliance, slow acting. So when to consider biologics? Failure of therapy including more than 2 DMARDs. Of course, these are the nice guidelines, but I feel if the disease is very active, the acute phase reactions are high, the rheumatoid factors are, and the patient is going with the pains and all, I think you can consider even with 1 DMARD failure. Moderate to severe disease activity despite conventional combination therapy. There are several biologic agents available. That itself is a big talk. Tumor necrosis factor inhibitors, interleukin inhibitors, and B-cell inhibitors, etc. So what is a biologic? They are large complex molecules. They are antibodies. The manufacturing is extremely complicated and sensitive to small variations. They are proteins actually. If you can take this picture, this one, the size difference between a small molecule and a biologic. If you take an aspirin compared to a monoclonal antibody, is established with a human being of 1.8 meters, 6 feet, with a height of 6 Eiffel Towers, that's around 300 meters. So that's how the biologic is a protein with having primary, secondary, tertiary structures. The traditional DMARD mechanism of action is hypothetical. Of course, it is very more understanding in methotrexate. Whereas biologic agents, mechanism of action is identified. And the slow onset of action, this is rapid, efficacy not sustained, but with the biologic they are sustained, easy to manufacture with the small molecules. Whereas it's difficult to prepare and advised by rheumatologists, but the biologic agents are prescribed by only rheumatologists. So this is the spectrum of rheumatoid arthritis. Non-biologic era, we used to use injectable bolts like myocrysine, aronofin, diphencylamine. And then we have a biologic era, that's from 2000 onwards till now. And then targeted era, that's a small molecules, they directly target the cell and then tyrosine kinase. I'm happy to say that most of these agents we have tried. I was a principal investigator in our center, has participated in global clinical trials in the phase 3 and phase 4 clinical studies for biologics and targeted synthetic molecules. The biological production is highly complicated. You start with a clone gene into vector, translate the vector into host cell, select optimal cell for production, cell culture expansion up to commercial scale, then downstreaming, then highly complex protein with 3 or 4 levels of structure. So you have to keep it in 2 to 8 degrees centigrade, and the carrying is difficult, and then they have to be injectable, either subcutaneous or IV. And they have, however, significantly advanced treatment of many disorders. For us, arthritis, and for dermatologists, psoriasis. You can see the dramatic response of our own patient, a 25-year-old person with a psoriatic arthritis. I don't treat psoriasis, but he has come with psoriatic arthritis, but such an extensive psoriasis. We gave secukinumab, IL-17 inhibitor, and then that's where 0 week, first week, second week, third, fourth, and then once in a month, 150 milligrams. Dramatic response. Within a month, you can see the clearance of the psoriatic lesions, the joint pains have come down, the index and PASI score has come down, and then the ACR score has come down. And of course, he has to continue once in a month, 150 milligrams subcutaneously. So the biologics are several. Tumor necrosis factor inhibitors on the left side, and most of them are available, either biooriginators or biosimilars, and then other than TNF inhibitors we have again on the right side. Then the site is a complicated site. This is just only to mention that why they are helpful and why they act and where they act. The cytokine signaling pathways involved in RA. The right side, all the 5 are TNF blockers, whereas tocilizumab, IL-6 inhibitor, rituximab, B-cell, abatacept is a co-stimulating. So there are several of them actually. So, and we do use whenever it is required. Of course, side effects are known: infusion reactions, infections, hematological, cardiovascular, demyelinating autoimmune malignancies. And what is a biosimilar? Biosimilars are actually produced by our Indian pharma, much cheaper rate, but it's also complicated. The manufacturing is equally complicated, but they are not identical. They are not identical, but they are similar, you can say. And they are not generics. Generics are easy to manufacture. but these are proteins. And we have small molecules, JNS kinase inhibitors, whereas biologics act, in the cell, TNFs like human necrosis factors, interleukins. So away from the cell, whereas the JNS kinase inhibitors act within the cell. So the production itself is inhibited by these targeted molecules. But easy to manufacture, they are called small molecules. So the tyrosine kinase inhibitors, serine kinase inhibitors, lipid kinases, etc. So this is itself is a big topic again. So we loosely call them as oral biologics. They are almost equally effective as injectable biologics. So these are the latest EULA recommendations. Again, this is not the GPs for us. The management of rheumatoid arthritis with the synthetic and biological disease modifying 2022 update, the Annals of Rheumatic Disease, Molen, the recent publication. So the points to ponder, last two slides, contraindications of the biologics. Active infections, current or recent malignancy. It is not within 5 years of any malignancy. Pregnancy and lactation, though some of the TNF blockers are being addressed to pregnancy and lactation. We should evaluate for latent tuberculosis. Vaccinations was very nicely mentioned in the previous talk. Special situations, peri-surgery, peri-operative, etc. They are all mentioned now. So do's and don'ts, the final slide. Do know about biologics and their role in the management of various arthritis and autoimmune diseases. Do know when good patient needs advanced therapy and when to refer the rheumatologist. But don't. So one don't, which is important, is don't prescribe yourself biologics. Not routinely given, needs sufficient experience. Side effects are there, you need regular monitoring. And for the rheumatologists as well as GPs, we don't advise two biologics together, two targets synthetic together, or synthetic target and others. So to conclude, early diagnosis and treatment are critical in the long-term management. Development of biologic agents opened a new era with more effective control, and the implementation of T2 target is excellent. Okay, thank you very much. Any questions I would like to answer?
Thank you, Dr. Iracon. That was a very informative talk with very clear guidelines to GPs. Now the house is open for any questions.
Or the tuberculosis in chest X-ray. So we have to have a thorough clinical examination before planning for any the targeted molecules or biologics. So your question, what we do in case SMART2 test is positive and patient needs biologics. Theoretically, we have to give treatment for latent tuberculosis, and our pulmonologist advise to isoniazid and rifampicin because single drug may give the resistance. And there are again controversies whether we should give the TB treatment for 1 month then start the biologic, but the latest literature says you can start that simultaneously.
So here again the question comes, first is INH single drug is not available. Many recommendations say that INH to be continued for 6 months or INH plus rifampicin to be continued for 3 months before starting biologics. And second is in Indian context, how much relevant is it? Because everybody of us who are staying in India, most of us will be MANDU positive.
1/3 of us.
So do you standard go by MANDU testing and then when it's negative, then only you start the biologics, or you give treatment? Because that's a Western recommendation. What is the Indian scenario?
Yes, Professor Malaga can help me and then I give you the other answer.
3 major papers we have written. The Indian Journal of Rheumatology paper is being followed by most of the rheumatologists in India. I will suggest that you read and many questions are answered. The answer is very straightforward. We have to do triple screening. Very simple. Montu's test can be done, but there is a proviso. If you are an immunologist, you know that the dose of antigen determines the response. Therefore, in a person who is suffering from systemic immunoinflammatory disease, his immune response is actually low because it is busy in killing the cell body, so it can't respond to something from outside. And that's why you have to increase the dose of the challenging antigen. So instead of if you give and compare with the 1 TU, you will find that the positivity is reaching 32% in the patients that you have tested. Then the question comes, what is the positivity of Montus in general population in India? And thanks the Ministry of Health has the information in lakhs of Indians using 1 TU tuberculin. And the percentage is 40% of the Indians are positive. So we have to now find 40% positivity, and then we will feel that we have caught all the latent tuberculosis patients with rheumatoid arthritis. But if you do Montus only, even with 10 TU, we are getting only 32%. So we will still be missing tuberculosis. So what we did, we combined quantiferon gold with 10 TU Montus test. And lo and behold, the exact figure we got positivity rate in rheumatoid was 41%. So that's the recommendation. Use 10 TU, and very difficult to get. Span Pharma in Ahmedabad is making it. It has not been standardized at the international level, but that is what is available, and that's what we are using. 10 TU Montus, 10 millimeter cutoff, along with quantiferon gold, positive or negative, and X-ray chest to rule out active tuberculosis, 4S active tuberculosis that everyone knows. I don't have to go in detail. Rule out active tuberculosis using 4S standard, and then you do Montus, 10 TU, and then you do X-ray quantiferon gold. If it turns out to be positive, straightforward recommendation. INH, if you can get, 9 months, single therapy, and no question of any resistance. If you talk to a specialist, they say, in latent tuberculosis, the question of resistance doesn't come, because that's not dividing at the same pace. The tuberculosis resistance comes in active TB only. So you can use INH alone for 9 months. Or you can be more quick in giving the combination, that is rifamycin and INH for 4 months, and that's sufficient. But if we get the rifapentin, we may come down to even 2 months very soon. Thank you.
So after starting therapy, when do we start biologics?
Sorry?
After starting the
that answer, now internationally, people saying you can start them together.
simultaneously.
Actually, all this is usually these ATDRs is not available in the market.
What?
Anti-tubercular drugs are not available in the market.
Arsenex is widely available. We are writing
we usually refer to the chest OPD or national tuberculosis elimination
have to do.
There is no such combination drug.
Arsenex is available. It has INH.
They usually do not recommend us. Just physicians.
We have gone through with Dr. Pandey, who is no more. We discussed with him, and All India Institute, Dr. Sharma, we have discussed in great detail, and they said rifampicin plus INH 4 months is sufficient. And then you read the literature. New General Medicine has the paper, and Honda has an extensive
About the
paper.
availability of the drug.
It's available, sir. It's available.
Now it's available.
One more question.
Do we need to start purchase the drugs from outside? Is government
The DCGI, Drug Control Journal of India, for the small molecules or the biologics, you have to announce that there is a failure of methotrexate therapy. Unless methotrexate is contraindicated or not tolerated, you may think of other DMARDs. We have other DMARDs like leprodomide, sulfasalazine, etc. So initially, I suggest that we should give initial time-tested and drugs like methotrexate, sulfasalazine, etc. So I do not give biologics at upfront. Yes, sir.
Before rituximab, you give vaccination all the time in each and every case for giving rituximab, because rituximab is commonly used in rheumatoid arthritis nowadays. And so do you use it? I check it IgG fraction. If IgG and IgM, if we check it, the prevalence of infection is much less if they are normal. What is your viewpoint?
Which vaccines? Are all the vaccines in general? Or?
Do you vaccinate? No, that is not the usual custom. Usual custom is not do this vaccination each and every time before you give rituximab. In each and every case, not at a time.
There is a practical way of.
Live, of course, we do not give.
If you are practical about it, every patient when they come, first time when I start treatment, I ensure that their pneumococcal vaccine and influenza vaccine has been given. Once you give that, then there is no problem. You can give rituximab without it.
Because we don't come across any major tuberculosis in cases you could find that.
Yes. Fortunately, the anti-CD20 and IL inhibitors, they do not give us much tuberculosis against the TNF blockers, because the TNF blockers may disrupt the ganglia, the granuloma, sorry, and especially monoclonal antibodies. So they are safer compared to the TNF blockers, and safer compared to the monoclonal antibodies, rituximab and IL-6 inhibitors like tocilizumab. But we do do the latent tuberculosis evaluation, even for them.
Right, after this informative first session, then we call upon Dr. Iracon, the head of the Department of Rheumatology in General Medical College, to deliver her presentation.
A very good afternoon to you all, and many thanks to the organizer for giving me this opportunity to speak in front of the patrons. So coming to the topic, why this topic is important? Because picking early is more important, because prevention is the only key for the prevention of osteoporosis. So with aging, life becomes lighter, and so are our bones. So this topic is important because when we see the data, every second lady is suffering from osteoporotic fracture in women, while every fourth person in men are suffering from osteoporosis. And 25% of those, they die within first year. And if you see the morbidity, it is more than the heart attack, diabetes, or breast cancer. So the burden is really heavy. And if you see the vertebral fracture, they are the most common site of osteoporotic fracture, followed by hip fracture. Otherwise, it can happen in any part of the body. So 20% of those who got osteoporotic fracture, they die within a year. And almost 80% of them, they are like disabled for the life. So this innocent evil osteoporosis, it is silent till we notice it's present. And we don't call it disease, it's a kind of state or a condition. So osteoporosis is characterized by low bone mass, microarchitectural disruption, and there is increased risk of flagellate fracture. So let's see through clinical vignettes. A young girl developed acute ankle swelling as she gets up from the bed in the morning. And she was investigated, she wanted to be very deficient of vitamin D. A young lady, 34 years, with a long history of surgical hysterectomy is now complaining of generalized aches and pains. So she was like estrogen deficient, so her bones become weak. A lean and thin woman of 25 years age fractured her wrist while lifting her baby. So that is flagellate fracture. Cause could be any other thing. A rheumatoid arthritis patient is always grumpy, although CRP is negative, there is no synovitis. So there was an underlying osteoporosis. Then a 70-year-old male develops scoliosis, sudden onset collapse with pain everywhere. On investigation, he was found to have multiple myeloma. So this is the spectrum of symptomatology of the osteoporosis. So who are the victims? Elderly people, postmenopausal women, sedentary lifestyle, alcoholics and smokers, diabetic, patient with rheumatic disease, cancer patients, low sunlight exposure, and then family history osteoporosis of falls. So who are the contributors to this osteoporotic condition? So if patient has got low peak bone mass, there is increased resorption like estrogen deficiency or decreased bone formation during remodeling. Then if patient has got hyperparathyroidism, renal osteodystrophies, osteomalacia, malignancy, or Paget's disease. So WHO has put some criteria to diagnose osteoporosis using T-score. T-score means there is a adult healthy population. So normal is if the T-score is -1 or above, osteopenia is -1 to -2.5, osteoporosis is -2.5 and below, and severe is osteoporosis plus 1 osteoporotic fracture. So symptomatology, if we see that we always look at the colored things, very obvious thing. We miss all these black things which are behind. So same thing happened with the osteoporosis. There is a generalized aches and pains. There will be a fragility fracture patient may come with, or symptoms of underlying disease might be there. So if you think that only postmenopausal women has got osteoporosis, no. Even the premenopausal women has got osteoporosis if they have got underlying diseases. This secondary cause is there, and their BMD is measured by the Z score, like their age matched. So the difference between the BMD and the risk of fracture is unmatched in premenopausal women. So what are the risk factors for premenopausal osteoporosis? If they are on long-term glucocorticoid therapy, they are on anticonvulsant drugs, medroxyprogesterone, or they are suffering from hypogonadism, pregnancy, lactation associated osteoporosis, hyperparathyroidism, hypophosphatemia, hypercalciuria, vitamin D deficiency, we all know that, or malignancy, celiac disease, and there is one more term, idiopathic osteoporosis. Here, males are equally affected. So we can always blame our genes for that. There is polymorphism of the genes which predispose premenopausal women for osteoporosis. So what you need to do is you need to pick all the threads together and then make a diagnosis and fix your goal. So screening for osteoporosis, how do you screen? Why? So the initial fracture assessment is done for the osteoporosis during screening. So all the clinical features you take care of, and then all the lab investigation like serum calcium, vitamin D, serum phosphate level, and renal functions, they are done. How to screen? The DEXA scan, dual energy X-ray absorptiometry, is the gold standard, but it is a big machine, it is expensive, and then it uses ionizing radiation, although it is in a very small amount. So we can detect the osteoporotic fractures from any site. So this is the picture of DEXA scan. You can see red is the danger zone of osteoporosis and green is normal. Whom to screen? Women of more than 65 years, all women should be screened. If they are less than 65, then postmenopausal women, if one risk factor is present, and in man, if the person is more than 70 years or more, or low bone mass, history of fragility fracture is there, or there is a collapse, or decrease in height of more than 1.5 inch, or again, those medicine and underlying diseases they are suffering from. Rescreen is redoing of repeat BMD. When it is done, it is valuable for the patient who are already on therapy for the osteoporosis, or there is underlying clinical factor which is still going on. There you can go for repeat BMD. So that needs to be counseled properly. So if the T-score is -2 to -2.4 plus one risk factor, you go for every 2 years. If no risk factor is there, T-score is -1.5 to 1.99, then you go for 3 to 5 years. And if the T-score is -1 to 1.49 and no risk factor, and the frac score is like probability fracture is more than 30% in other area or 3% in the hip fracture, then you can go for repeat BMD 10 to 15 years. So we all know that about this fracture, we assess the assessment for the probability of fracture. So we do that. Then sometimes it is always good to think out of the box. Many times dentists will tell you that, okay, doctor, you come and see this patient because this patient is suffering from osteoporosis, because they pick the osteoporosis from the dental bone, from the jaw bone. There are other techniques also, but they are not used for screening. They are used where the DEXA scan is not possible or it's inaccessible. So quantitative computer tomography, quantitative beam ultrasound, or other peripheral measurement can be done, peripheral DEXA scan or peripheral quantitative computer tomography, that can be also done. There are few biomarkers which can help in diagnosing osteoporosis, which are specific for bone formation or for bone resorption, but that is more for research purpose. We generally don't do it, except alkaline phosphatase and bone specific acid phosphatase. Regarding management, the non-pharmacological management is like exercise, because you need to build your muscles strong. Girna mana hai actually if you have got osteoporosis. Take good care of the diet, sunbathing is good, and never underestimate the power of suntan. So lifestyle modification, be active and quit smoking and alcohol. So you can choose this diet for them which is rich in calcium. So who needs treatment with the medications? So all the people who are at risk of fractures, postmenopausal women and older men with T-score less than -2.5 or FRAX score is 3% or 20% as I said. Then in pre-menopausal women who needs treatment, who has got an underlying cause and the risk factor is still going on, that should be treated. In the pharmacological armamentarium, we have got bisphosphonate, pamidronate, alendronate, risidronate, ipandronate and zolendronate. Then we have denosumab, romosozumab, recombinant, parathyroid and calcitonin. So bisphosphonate, these are anti-resorptive agents. So they slow down the breakdown and remove the bone, which is like resorption. They are widely used for the prevention and treatment of osteoporosis in postmenopausal women. So the regime you can choose it. It is weekly or monthly or yearly. Like zolendronate we give yearly, ipandronate we give monthly, or alendronate we can give it weekly. So instruction should be given properly for the oral bisphosphonate, like they should be taken in empty stomach, they should be taken with a big glass of water, and the patient should not lie down for at least half to 1 hour. They are well tolerated, but there are few side effects like pill, gastritis is very common, GERD is very common, so you should take care of that. Then we have selective estrogen receptor modulator, which produce estrogen-like effect on the bone, and but they should not be given in premenopausal women osteoporosis. And the example is raloxifene and tamoxifen. Then there is hormone therapy, but these hormone therapy like estrogen, it should not be given in the post-menopausal women because of the chances of cancer. Then we have a denosumab, which is a monoclonal antibody that acts against a specific protein which involved in the formation of cells that break down bone. So when it is break down, this protein, the bone formation is enhanced. It improves bone mineral density and reduce fracture. Then we have calcitonin, but we don't use it very often since the advent of this newer drugs. Then we have anabolic agents. They only recommend for people with severe osteoporosis, and they work by stimulating the bone formation. We have parathyroid hormone, a parathyroid hormone related protein. They are effective in the treatment of post-menopausal women and men, and it is given by daily subcutaneous injections. They are given only for 2 years, then it is replaced by oral bisphosphonates or anti-resorptive. Then we have romosozumab, again as block of protein scleractin, which stop new bone formation from being formed. Thus it blocks that protein which allows the body to make new bone formation. It is a monthly injection, subcutaneous, can be given. It is used only for 1 year, then again replaced by anti-resorptive drug. So remember, osteoporosis is recognizable, treatable and reversible disease. Public awareness matters, and so is the doctors. And of course, suntan is important. We have already discussed that prevention is the only key. Recognize this hidden enemy always, don't forget it. And Vikas, and thank you from this liberated osteoporotic free women from all sides. Thank you.
Thank you, Dr. Iracon. Now any questions from audience? I have one question. Is there any special precaution?
Need not to go for the diagnosis since it should be given. And plus, if the patient is of rheumatic disease or patient is older than 65 years old, then you should give it. The only thing is that you should take care of the patient should not have gastric ulcers.
Nobody practice if we see a geriatric patient who is E-dental and has poor oral hygiene. Do we need
Sorry?
a geriatric patient who is E-dentulous or having a poor oral hygiene? Should we need to get a dental fitness before starting bisphosphonates in figure of OA injury?
The paper has not proved it that any research that they cause jaw necrosis positively. It's a chance and it is very rare. So you can always go for osteoporotic therapy without this thing. If the patient is already having this thing, then there is a general, predilection for the fracture because the edentulous patient, they will try to manipulate it and already the bone is porous. Then it is a problem. Otherwise, it will not cause jaw necrosis as such. And you need not to stop. And you need not to stop medicine if the patient is going for dental checkup or dental manipulations.
Patients who are already having nephrocalcinosis without any symptoms, how about the calcium recommendation already?
Calcium needs to be replaced basically. 1200 milligram per day should be given because if the patient is osteoporotic, right, and you want to start anti-resorptive drugs, bisphosphonate, they are all hypocalcemia, they cause hypocalcemia. So you need to build calcium before giving it. And you take care of this also.
In spite of nephrocalcinosis?
Yeah.
Thank you.
I think that will be all.
Yeah, thank you very much.
Good afternoon everybody. My topic is a hyperuricemia, when to treat and when not to treat. It should be not a lecture, it rather should be a debate. Because in last few month ago, in 2021 April issue, Mungas Tiaskar is our secretary, APL secretary. He has done a survey, an assessment of knowledge, altitude and practice for the physician in the management of hyperuricemia in India. It's a questionnaire-based study. And he has seen, it has been rather shown in this article that majority of the lecture in physician, what they have done, it is not good, but it is not proper. And it has been criticized by one of the saris here, Dr. Malavya and Dr. Rohini Handa. After 2 months, they have criticized that it is not a proper survey or proper opinion to the physician. So this should not be done. So still date, it is a debate. It is we are not sure to which one to treat and which one not to treat. It is a differ from America to Europe to Asia. So with this short introduction, I start my lecture. And because the disease of gout is a very much ancient disease, it is a 5th century BC, Hippocrates described the gout. And you know about the uric acid, basically it is the waste product that results from the body's normal process of the cells dying and releasing purine from the ATP, GTP and nucleic acid as well as from the body absorbing purines contained in the food. And what the purine, either dietary purines or tissue synthesis metabolism, purine is excreted through the kidney by 70% and 30% through the intestine. If the kidney is deformed or in a chronic kidney disease, intestine takes major part of this excretion. So what is the value of serum uric acid? When I define is it a hyperuricemia, there is no actually specific data. It differs from man to man. So it depends on the saturation point, which is usually 6.2 at the temperature of 37 degree. For discussion or for our benefit, we usually make it the upper limit for the male is 7, in a female is 6. It lowers in the children, it increases with the age. And in hyperuricemia, data of the prevalence in India is 25 to 8%. And if there is any problem due to the excretion, there is a chance of hyperuricemia, because urate excretion mainly occurs in the kidney and is responsible for the hyperuricemia in the 90% of the individual. It is the under excretion is the main cause, and that is due to the decreased glomerular filtrate, decreased tubular secretion, and enhanced tubular reabsorption. So these are the major causes of that, including the hyperuricemia due to renal insufficiency, which when the uric acid level increases, when creatinine clearance falls below the 20 ml per minute. And few drugs that also causes the hyperuricemia, and also some clinical condition or comorbidities which is commonly associated with the hyperuricemia. The result under excretion is the main cause causing the hyperuricemia. Where is that is the hypertension, hypothyroidism, that's also. And also overproduction is also another cause. And urate production is accelerated by the purine-rich diet. That is not so much common. But endogenous purine production and high cell breakdown is responsible for the minority cases of hyperuricemia, but this is very much common to our physician. And because apart from this enzyme deficiency, there is a lots of disease coming from this hematology department, particularly increased nucleic acid turnover, mainly the lymphoma, myeloma, leukemias, also present with the uric acid. When you can diagnose the patient where, hidden malignancy, then you can take as a point what is the LDH value, what is the uric acid value, and then research for is there any hidden malignancy. So these are the overproduction list and these are the underproduction list. These are the causes of hyperuricemia. And it is gradually increasing because the longevity is increasing, prevalence is there, hypertension is increasing, diuretics is increasing, alcohol consumption, obesity, so much other comorbidities are there. That's why incidence of hyperuricemia in India is gradually increasing. The problem is that what is, as a physician, what we do when a patient comes with hyperuricemia? You can diagnose, you as a physician, you just examine the patient, but no specific physical examination finding will be there. If the patient is associated with a complication like a gout, you can get some points. Or if the patient has a nephrolithiasis, you can get some hematuria or renal angle tenderness. You can take a help of that laboratory. So you just, apart from uric acid, if you get uric acid level more than 8, then you repeat it. Repeat it after 1 week. And you confirm, routine screening for hyperuricemia is not recommended. But you have to check for whether it is some myeloproliferative disease or lymphoproliferative or due to the renal failure. You have to do CBC count, electrolytes, urea creatinine, liver function, and glucose, repeat, or other comorbidities like calcium, phosphate, and thyroid. You have to exclude others, like other joint swelling, and ultrasound, and also required if the patient is complicated with nephrolithiasis and others. So when a patient comes with hyperuricemia, either may present with a silent asymptomatic hyperuricemia or associated with complication. So it may present with asymptomatic hyperuricemia or acute flare with gout, or in between the intercritical segment phase of the gout. You have to go, rather you have to inquire whether the patient has taken any urate lowering drugs in the past or not, whether he is in the intercritical phase or not. And after that, you have to choose which will be treated and which will be not treated. But in case of, if you think of it is a case of gout, but all hyperuricemia or gout are not synonymous. All hyperuricemic patients are not gout. Most people with hyperuricemia never develop gout, and few gouty patients have normal serum uric acid level. But why during the management of hyperuricemia, first you have to think for what is the cause of hyperuricemia. Are associated findings are present? Has damage to tissue or organ occurred as a result? Or what, if anything, should be done? So, as it is associated with all other comorbidities, you have to look for others also. So, you have to look for the renal and heart disease mainly. The question arises that persistent asymptomatic hyperuricemia imparts risk for the development of urate and uric acid crystal related clinical events, and that the respective risks are at least in part related to the magnitude as well as the duration of the hyperuricemia. So it is the duration and the uric acid crystal may produce some complication, and for this reason whether you have to treat or not treat. So factors considering asymptomatic hyperuricemia when to start. In 70% hyperuricemic patients, our underlying cause can be readily defined by history and physical examination. Most patients with asymptomatic hyperuricemia never develop gout. So treatment of asymptomatic hyperuricemia carries some risk. It is not considered beneficial or cost effective, and generally is not recommended except if the patient is on chemotherapy or radiotherapy, if the patient has a history of renal stone, or patient with a gouty tophi or moderate renal functional impairment, very strong history suggestive of family history of gout, urolithiasis or uric acid nephropathy, and patient with a very high level of serum uric acid. What is the level? That I am coming later. So, indication of pharmacological urate-lowering treatment according to ACR guideline in 2020, and they have for patients with asymptomatic hyperuricemia when the serum uric acid level is more than 6.8 with no prior gout flare or subcutaneous tophi, we conditionally recommend against the initiating of any pharmacological urate-lowering therapy. So they have not recommended in this group. But you have to start when it is associated with gout, associated with acute uric acid nephropathy, uric acid nephrolithiasis, or chronic renal insufficiency. But in case of a gout, you can start, if you diagnose the gout with renal failure or gout with a symptomatic, then the patient, usually we start allopurinol. Allopurinol is the preferred choice according to our ACR guideline, which is published in 2020. But there is some other comorbidities related with the hyperuricemia. There is changes, particularly in CNS and cardiovascular and kidney changes are there, which makes a confusion about the management of that. Hyperuricemia may modestly increase the risk of stroke, incidence and mortality. If reducing the patient uric acid level, that will have beneficial effect relating to the stroke, that has to be, that further research is needed. That is not finalized. So if you treat with this patient with hyperuricemic patient with urate drug, the stroke, incidence of stroke is not reduced. But higher level of urate may, through an antioxidant effect, reduce the risk of degenerative and inflammatory neurological disorder like Alzheimer's or Parkinson's. That is also helpful. Hyperuricemia rather helpful in Alzheimer's and Parkinson's. In a coronary artery disease or coronary heart disease, increased incidence of CHD and increased mortality in those with or without pre-existing coronary heart disease. Proposed mechanism for such increased risk include development of hypertension and oxidative stress. I mean, hyperuricemia related hypertension and oxidative stress may cause that. But it is unclear if hyperuricemia has a causal effect, or as has been more suggested, a simple marker of other disease factors such as hypertension, dyslipidemia and diabetes. That is not proved, or whether it is a directly causal effect or just is an association. So as a risk factor of mortality in patients with heart failure, it has been seen those patients with heart failure who have hyperuricemia, there is a much more chance of mortality. But it has been seen that if you treat the patient with an anti-urine lowering drug, the mortality has not improved. And it is also applicable in a chronic kidney disease. And chronic kidney is due to the reduction of the efficiency of the uric acid excretion and unaccompanied by the hyperuricemia. And causal role of hyperuricemia in CKD has not been established, just as a comorbidity. And many studies have been demonstrated a link between the hyperuricemia and CKD and the cause-effect relationship that has been debated. But the impact of urine lowering treatment had a mixed result in the published research. Until recently, there is a controversy, although not guideline recommended, to treat the patient with mild CKD and asymptomatic hyperuricemia with allopurinol, as an epidemiological study suggested a benefit in slowing progression of the CKD. So this study, actually, this is the FIGS DI, which is published in 2019. He has shown that lowering, in a hyperuricemic patient in a CKD, and that it has been shown that if you treat the patient with this hyperuricemia urine lowering drug, that is the patient, the mortality has been improved. And effects of allopurinol and progression of the chronic kidney disease, it has been shown that despite a significant reduction in the serum urate, there is no evidence of slower of GFR decline in the allopurinol group. It is published in 2019. So there is no effect if you treat with the allopurinol. Another study in diabetes care from the America, and it has been shown that despite the sustained lowering of serum urate over a 3 years period in the allopurinol group, there is no appreciable change in the GFR. And so it has been impact on hyperuricemia and chronic kidney disease and atherosclerotic disease, that there is no role. But in this study, in a BMC nephrology study, and they have seen that the evidence suggests that allopurinol and felustrate are the urate lowering drug of choice in reducing the composite renal events and improving renal function. So that's why, when to start this drug, particularly if the patient is asymptomatic hyperuricemia with MSU crystal deposit through your imaging, in that case, you have not to treat the patient with this drug, because this is not related to any development of gout or any symptomatic improvement. So very high level of uric acid, when the uric acid level is 12 to 13 or 10 milligram in a woman, you have to treat the patient. Better if the patient is a uric acid level just above 8, then you just check for them and you just follow up them. Portuguese guidelines said up to the 9, Japanese guidelines said up to the 8, and ACR guideline does not recommend in asymptomatic hyperuricemia to treat the patient. They treat the patient when it is 12 to 13 in a male and in a 10 in a female. So you can take a help of the urine value, whether it is a overproduction. Just take the, whether it is a more than overproduction, 24 hours collection or spot collection. From that you can check whether it is a overproduction, then you have to treat the patient. So treatment with allopurinol is a preferred first line drug, that I've already said. But another debate is that how many days you have to treat. Is it a intermittent or is it a just treat to target? American College of Physicians, they have recommended treat the symptoms. They have recommended intermittently, just give when it is required. But ACR guideline says that you have to treat the target, not to the symptom. That is also very important. So there are few points of debate in the treatment or management of hyperuricemia, particularly asymptomatic. Where is the cutoff value and how many days you have to treat and what to level you have to treat. That is still debated. And lastly, I can say that don't ignore the patient which is asymptomatic hyperuricemia. Particularly, you take a special precaution for them, and you have to check the other associated metabolic syndrome is present or not. You take the help of phenylpiprate and other losartan, which will be helpful in a treatment of the dyslipidemia and also hypertension. And don't treat the patient of asymptomatic hyperuricemia if it is not indicated what we have already said. Thank you very much.
Between primary care doctors and rheumatologists, do's and don'ts. Primary care physicians are those doctors who are working in primary health centers and community health centers, and they provide both the first contact for a person with an undiagnosed health concern and continuing care of varied medical conditions. In 2019, Durga Prasad Mishra et al. They planned a survey of 333 respondents were there, and the crux of the study was that only 20% Indian doctors had adequate exposure to treat autoimmune rheumatic diseases during interval with the medicine residency. And 83% felt further training and sensitization in rheumatology is needed. In 1998, British Journal of Rheumatology published an article on referral and diagnosis of common rheumatic diseases by primary care physicians, and 300 primary care physicians in 1994 who referred the patients to rheumatologists were data was analyzed, and rheumatologist diagnosis was kept as the gold standard. 49% were defined as rheumatic disease by primary care physicians, and out of these, 41% of the patients, PCP and rheumatologists disagreed on the diagnosis. The diagnostic agreement between rheumatologist and PCP was low. Highest agreement was observed for the crystal-induced arthritis between PCP and rheumatologists, and ankle-inducing spondylitis, 81% and 94% respectively. The sensitivity was lowest for the primary care diagnosis of fibromyalgia syndrome. The lowest agreement was observed for lupus and polymyalgia rheumatica. Then in 2004, Joint Bone and Spine Journal, there was an article, do primary care physicians have a place in the management of rheumatoid arthritis? The crux of the study was that PCP overdiagnosed eye. PCP rarely prescribed DMARDs. Mean time from symptom onset to starting DMARDs was 19 months. Timely referral is important for the better outcomes for the drugs. And need for educating the internist and PCP was recognized. They should work together for optimal management of the RA patients. And the PCP should be aware that early detection and prompt referral are of utmost importance to ensure early second-line treatment. Second-line treatment means DMARDs. At that time, it was known as second-line treatment. Then in 2016, Fossum, he managed this management of rheumatic disease, the interface between primary care and rheumatology. This article was published in Rheumatology Advisor. And again, the crux was that role of PCP as initial gatekeeper should be shifted to a greater role in diagnosis and treatment. Initial use of steroids was more by PCP and led to masking of the autoimmune rheumatic diseases, leading to either underdiagnosis or misdiagnosis of the patients. More GPs than rheumatologists initiated steroids before referral. More rheumatologists than GPs recommended immediate referral to a specialist. So it was recommended by rheumatologists that more patients should be referred to them. There are ACR guidelines for referral to a rheumatologist for diagnostic evaluation of patients with unclear diagnosis like fever of unknown origin, unexplained clinical features like arthritis, fever, rashes, etc. Increased ESR in positive rheumatoid factor ANA, then diagnostic evaluation of long-term management of autoimmune rheumatic diseases like inflammatory arthritis. They have included almost all the diseases: inflammatory arthritis, connective tissue diseases, vasculitis, fibromyalgia, complex regional pain syndrome, crystal arthropathy, sarcoidosis, and metabolic bone disease, osteoarthritis. Then to confirm and help formulate and or participate in a treatment plan. And diagnostic or treatment plan evaluation for rheumatic manifestations of other primary diseases like infections, paraneoplastic, neuropathic, endocrinal, hematology. Then provide second opinion or confirmatory evaluation when requested by the PCP. So these were the ACR guidelines, but there are no Indian guidelines. So we were taken aback when I was given this topic, what to do. So I convened a survey and to assess when the PCP should refer to a physician. And there were 61 responses, 35 were rheumatologists, 26 were physicians or non-rheumatologist specialists. Various questions were asked regarding the autoimmune rheumatic diseases. I know there are shortcomings of this survey also, at the end we will discuss. So there were various questions. So when a patient comes with recent joint pain and swelling for the first time, should a PCP refer the patient to a rheumatologist? And no was by 57.4%. The opinion of internists and rheumatologists did not differ much because the statistical difference was not there. So 57% said the patient should not be referred to a rheumatologist. When a known case of seropositive rheumatoid arthritis comes to a PCP, should he or she refer the patient to a rheumatologist or start the treatment himself or herself? And there were 72% said that the patient should be referred to a rheumatologist, and more so by the rheumatologist, 89%, and 50% the internist said that the patient should be referred. And this was significant difference between the opinion of internist and the rheumatologist. Then when we come to third question, a patient treated by rheumatologist develops adverse events to treatment that are, what are the events when a patient should be referred to a rheumatologist? So there are nausea and vomiting, only one internist and 6 rheumatologists felt that the patient should be referred to a rheumatologist. Leukopenia, 84% said that the patient should be referred to a rheumatologist. Opinion of internist and rheumatologist varied significantly. Increased SGOT, PT, 70% said that the patient should be referred to a rheumatologist, and this difference between the internist and rheumatologist was not significant. Pneumonia, 67% said the patient should be referred to a rheumatologist, and again this opinion between the rheumatologist and internist was not significant. Pancytopenia, there was a significant opinion difference between the rheumatologist and internist. 86% said that the patient should be referred to a rheumatologist. Toxic epidermal necrosis, 77% said the patient should be referred. Again, there was a difference of opinion between rheumatologist and the internist. Cushing-Watt features secondary to the chronic steroid therapy, there was 69% each said that the patient should be referred. Then infections which are secondary to the treatment, 88% said that the patient should be referred to a rheumatologist internist, and 53% rheumatologists felt that the patient should be referred to them. So there was significant difference. The rheumatologist felt that the 47% rheumatologists felt that the patient can be treated by the internist, while 88% internists said that the patient should be referred to a rheumatologist. Then a patient with RA develops complications, for which complications a patient should be referred to a rheumatologist. So for flare ulcers, 77%, 73%, again difference of opinion, significant. Then gangrene, 81% internist said, and 100% the rheumatologist felt, significant difference. Pyoderma, 95.1% said that the patient should be referred, and significant difference, 88% versus 100%. Then ILD, 85% versus 100%, so again a significant difference between the, but most of the, you see here 93% said that the patient should be referred to a rheumatologist. Ocular complications, 88% said that the patient should be referred, and this difference was not significant. Septic arthritis, 81%, 80% not significant opinion between the internist and the rheumatologist. Then atlantoaxial dislocation, and there was 78% said that the patient should be referred, 81 versus 77% of the rheumatologists. Then patient having lupus. What are the complications where the patient should be referred? Then lupus, patient develops a fever, 80% said patient should be referred, and there was this significant difference between because 65% internists and 91% of the rheumatologists felt that the patient should be referred to them. Then you see here, for all the complications like renal involvement, extensive skin involvement, lung involvement, seizures, psychosis, lupus patient with pregnancy, autoimmune hemolytic anemia, severe thrombocytopenia. The rheumatologist's opinion was that the patient should be referred to them, and only in the lupus pregnancy, the difference was not significant. That is, both agreed, internists and rheumatologists, that the patient should be referred to a rheumatologist. Similarly, for extensive skin involvement, there was not much of difference between internists. The rest all had significant difference of opinion between internists and rheumatologists who are referred. Then, should a suspected case of vasculitis be referred? 91% said yes, patient should be referred to the rheumatologist. And again, there was difference in the internists. 80% internists felt that the patient should be referred, where the 100% rheumatologists felt that the patient should be referred to them. Then, a patient of suspected gout, should the patient be referred to a rheumatologist? 51% said no, patient should not be referred, and here also the difference was not significant statistically. Then idiopathic inflammatory myositis developed dysphagia. Should he or she be referred to a rheumatologist? 95% said that the patient should be referred, 88% versus 100% of rheumatologists. Then a patient of joint symptoms or vasculitis develops hemoptysis, bilateral patchy opacities, that is suspected to be pulmonary hemorrhage. Should the patient be referred to a rheumatologist? And 93% opined that the patient should be referred, and again 85% of internists and 100% of rheumatologists. Then a patient of RA lupus develops congestive heart failure, 73% said that the patient should be referred. This means suspected myocarditis. And 69% of the internists and 77% of the rheumatologists felt that the patient should be referred to them. A lady with recurrent abortions, suspected to be antiphospholipid, 86% said that the patient should be referred, and there was not much of a difference between internist and rheumatologist, 85, 86. They also find that the patient should be referred to a rheumatologist. A patient of systemic sclerosis develops oliguria, that is renal crisis, gangrene, shortness of breath. Then 98.4% said that the patient should be referred, and again the internist and rheumatologist were of consensus. A patient of spondyloarthritis develops uveitis, then desmophytes, inflammatory back pain, not responding to NSAID. Then 100% said that the patient should be referred to a rheumatologist, and this is 97 because of one rheumatologist failing to respond. Then a patient with rheumatic disease suddenly develops pancytopenia with high ferritin, multi-organ involvement, suspected to be macroreactivation syndrome. Then 100% response was the patient should be referred. Then I asked the question, what can be treated by PCP? And there were multiple responses. After making the correct diagnosis, starting treatment by rheumatologist, follow-up can be done at the PSC level. Ideally, after achieving the remission or low disease activity, follow-up can be done at the PSC level. And there will be some repetitions also, so excuse me for that. Most inflammatory, I have written as such, what would be responsive. Most inflammatory joint disorders can be managed by PCP, however, should be in conjunction with rheumatologists, so that in the event of an untoward or clinical or laboratory features, patient can be promptly referred. Flares of common arthritis, patients with milder symptoms, diagnosed rheumatic disorders with infections, minor flare or minor issues can be treated at periphery. Stable patients of autoimmune arthritic conditions on treatment, any disease in partial or total remission with no side effects of the drug can be managed by PLC. Joint pain or short duration, follow-up of the patient can be done once treatment regimen has been prescribed by a rheumatologist for most arthritic and lupus patients. But physicians need to be trained first for the rheumatological diseases. Then RA in remission, low disease activity, RA without complications, RA follow-up, stable RA, follow-up RA in consultation with rheumatologist. Then osteoarthritis, gout, osteoporosis, stable spondyloarthritis. Then infections, viral arthritis, post-viral arthritis, tubercular arthritis, septic arthritis, Sjogren's syndrome, one respondent that can be treated at the PHC. Then fibromyalgia, soft tissue rheumatism, mild sinusitis, mechanical backaches, meniscal tears, low back pain, cervical spondylosis, initial management of spondyloarthritis, reactive arthritis, tendinitis, flares of common arthritis, first episode of or flare of gout. This study, again by Dr. Durga Mishra et al., was published in IJR, Rheumatology Practice and Training in India, a perspective from the rheumatology consultants. So the pragmatic solution was might be to train internists from established internal medicine departments at medical colleges and district hospitals, or for internists practicing in private sector settings with teaching capabilities. This was the recommendation. So the summary is all patients with ARDs, that is autoimmune rheumatic disease, who are stable and in remission can be treated by PCP. This appears to be opinion of internists as well as of rheumatologists. Rheumatological emergencies, complications of rheumatic diseases may be preferably be treated by the rheumatologist. And the referrals to rheumatologists can be substantially reduced by imparting training to primary care physicians so that they can tackle many problems at periphery. Consequently, the cost of treatment burden on patients and overburdening of rheumatologists can be reduced. A streamlined referral system would help the rheumatologists take better care of patients with rheumatic diseases who develop emergencies and complications. And many thanks to Dr. Goel, who happens to be the chairperson also, for helping me a lot in this presentation, and Dr. Monica Rathod, Professor PSM, who derived all the values and thanks for the patient care. And thanks to Dr. Malia also, Dr. Honda, Dr. Kumar, who all participated in this.
And many of my friends, colleagues, and postgraduates. This is a great opportunity to meet all the section of the population here to deal with the emergencies and urgencies in rheumatological disorder. I've specially chosen as urgencies and emergencies that comparable to hypertension. Prevalence rate is actually 15 to 20%. If you take stock of the international literature, we do not have a literature from our country, but this is around 15 to 20%. Pathophysiologically, I think any of the mechanism may be operational in the genesis of complications like disease flare, direct organ involvement, necrotizing vasculitis, thrombotic disorder, sepsis, mechanical complication, and iatrogenic panic. Classify the urgencies and emergencies according to the category 1 and category 2. Category 1, common but urgent, window period beyond 8 to 24 hours. For the category 2, less common but life-threatening or vision-threatening, and window period 6 to 8 hours. Category 1, mostly are acute hot joint, infection, flare, peripheral vascular disease, adverse drug reaction, osteoporosis and fracture, and seizures. Category 2 is APLA, Assertion syndrome, macrophage activation syndrome, pulmonary renal syndrome, CNS vasculitis, anti-Rowe syndrome, scleroderma renal crisis, atlantoaxial dislocation syndrome, ocular emergencies, and others. And these are all life-threatening or vision-threatening. Acute hot joint, all of you know, either in monoarthritis or oligo or polyarthritis, mostly important sepsis, gout, trauma. Clinical diagnosis, we divide in two sections. Joint aspiration and synovial fluid analysis is an important step to distinguish septic from crystal arthritis, and cutoff point is around 20,000 with a neutrophil of 90%. This is a patient of mine with rheumatoid arthritis, SLE, who has got arthritic manifestation, developed septic arthritis, and had to be aspirated. And the patient had got residual deformity. And this was the situation of the knee joint after the patient recovered from the acute illness. This acute low back pain, most common in high-risk individual, types mechanical and inflammatory. Red flag signs are actually thoracic pain, fever, weight loss, extremes of age, steroid abuse, and neurodysfunction. Favorable natural history in majority of cases, and most of the time we initiate urgent attention. Particularly red flag signs are cauda-equina syndrome, bladder bowel disturbance, cord compression, hypotension, pulse irregularity. And in that case, urgent CT and myelogram and surgical intervention. If it is not there, we go for the medical treatment. This is one of the patients who had that anesthesia, spinal anesthesia, developed low back pain, acute in nature, and it comes out with epidural abscess, which has to be drained before the patient goes into myelopathy. Septic arthritis, bottom line, bacterial arthritis, most dangerous form of acute monoarthritis, which results in cartilage destruction. Arthrocentesis and synovial fluid analysis mandatory, and immediate broad spectrum antibiotic, and mostly they are staphylococcus, and someone may be Klebsiella. And orthopedic consultation. This is one patient of 8.5 uric acid, acute gout, can present acute emergency, but it is urgent, not emergent. Acute synovial rupture, again in one of the type 1 or category 1 complication, occurs in rheumatoid arthritis, osteoarthritis, associated with Baker cyst, and differential diagnosis, thrombophlebitis, hemorrhagic crescent signs around the ankle is diagnostic, decompression is necessary. This is one of the example of meniscus sign on the right ankle, and you can differentiation must be from the Baker cyst, which is ruptured. And immediate you can go for the ultrasonogram or MRI to distinguish one from the other and make a diagnosis. This is one of my patients who has got right-sided consolidation with symptomatic effusion in 54-year-old woman in 2010. She was basically immunosuppressed. This is another patient of mine, herpes zoster, with left trigeminal nerve involvement in systemic lupus. This is another example of rheumatoid arthritis on methotrexate for long term, develop microabscess in the patient in the liver. And this microabscess is not an amoebic liver abscess, microabscess which required antibiotic treatment to go along with the methotrexate and hydroxychloroquine to follow. This is another example of patient of systemic lupus presented with refractory seizures and has got miliary tuberculosis and has developed the brain tuberculosis, multiple tuberculoma. Then comes the lupus flare, one of the urgent complications, which can be minor flare or major flare. Minor flare and major flare distinction. Low dose steroid will be enough when out with an NSAIDs, but in major flare, you have to add some high dose steroids along with the immunosuppressive drugs. This is a lupus flare, classical. This is a patient of mine which I lost, who came with toxic epidermal necrolysis along with the lupus, and in 2006, and we could not do anything, we could not salvage her. Digital gangrene, most of the mechanisms are vasculitis, thrombophilia, and infection. More common in rheumatoid arthritis, lupus, and necrotizing vasculitis. Doppler flow study is important. We go for the cyclophosphamide, antibiotics, and ultimately needing amputation in some cases. This is a patient of mine who has got systemic lupus and nephropathy, has developed gangrene, and it has to be amputated in 2012. This is again a necrotizing vasculitis, which is in case of polyarthritis nodosa. This is another, now comes the drug reaction, erythema multiforme following sulfasalazine with target lesions and bulla. This is Stevens-Johnson syndrome, classical in a patient of lupus who is on that developed that Stevens-Johnson syndrome following the drugs and NSAIDs. This is another patient of mine who has developed adverse drug reaction of the gastric ulcer in 2005. This is another patient of osteonecrosis following the prolonged exposure to steroid, and he has got AVN on right shoulder, which is very unusual. More commonly we are seen in the hip joint, but it was in the shoulder joint. Seizures in SLE and primary CNS angiographies, it is most important feature of seizure, which can be single attack. When it's more than one attack in 48 hours, we call it epileptic attacks. And we try to understand what is the cause of this, and we go for this battery of investigations, including EEG, MRI, and CSF study before we go for the anti-epileptic treatment. This is down to category 2, which is life-threatening or vision-threatening. Catastrophic antiphospholipid antibody syndrome, mostly seen in primary APLA, and infection is the precipitating cause, sometimes surgery or contraceptives. And most of these patients die of stroke, renal failure, and alveolar hemorrhage. And we have to manage the multidisciplinary team with non-fractionated heparin, followed by warfarin or low molecular weight heparin. They have got a mortality of 50 to 60%. This is a DVT in a case of SLE with APLA. This is the vascular occlusion APLA. Macrophage activation syndrome, acute and severe presentation liver failure, fever, consumptive coagulopathy, jaundice, rash, hepatomegaly, splenomegaly. Most commonly associated Still's disease, but one of my patients who developed is the SLE patient who developed MAS. And they are treated usually with steroid and cyclosporine. This is an example of MAS with widespread purpura with hepatosplenomegaly and thrombocytopenia. This is the bone marrow examination of the same, showing a hyperactive macrophage in a case of juvenile inflammatory arthritis. Then comes the pulmonary renal syndrome, acute renal failure with rapidly progressive pulmonary nephritis or C-anchor vasculitis. Chest X-ray show pulmonary opacities. These are patchy opacities and not associated with the pleural effusion, which happens to occur in cardiac failure. Treatment with methylprednisolone, followed by azathioprine or mycophenolate, apheresis invasion, anti-GBM antibody. This is the different causes of diffuse alveolar hemorrhage and pulmonary renal syndrome. Wakefulness granulomatous accounting for 55 to 77%, microscopic anxieties, good posture 12 to 15%, SLE less than 10%. Most of this time they are treated with steroid, cyclophosphamide, sometimes rituximab may be helpful. CNS vasculitis in inflammation arteries and veins, occlusive ischemia and necrosis, and mostly associated with systemic lupus, Behçet's neurobichets, and necrotizing vasculitis. They are being treated with anti-seizure drug, methylprednisolone, IV cyclophosphamide. Anti-Roe syndrome, transplacental congenital anti-Roe at around 30th week of pregnancy, characterized by congenital heart block, generalized annular erythema, and hepatobiliary dysfunction. They require dexamethasone, which is fluorinated, that crosses placental barrier. Neonatal lupus, but they usually revert after 6 months' time. Scleroderma renal crisis happens to occur in 10% cases. Those patients who are on long-term, high-dose steroid, more than 40 milligrams, which causes arterial vasoconstriction, and they develop anti-RNA polymerase III antibody. We are treating the patients with mostly ARBS and dialysis. 40% require long-term renal replacement therapy, 5-year survival 65%. This rheumatoid arthritis, the atlantoaxial dislocation, happens to occur in rheumatoid arthritis when there is a neck pain and there is a vertigalgia and there is myelopathy, and decompression is necessary. Ocular emergency, painful right eye or painless blind eye. Particularly important, painless blind eye, ischemic optic neuritis. Cranial arthritis, the right ptosis. This is cranial arthritis, ischemic atrophy. This is acute abdomen with the gangrene of the small intestine. Maybe presentation with acute pancreatitis, acute cholecystitis, and acute appendicitis. Mesenteric ischemia present with acute abdomen with bloody diarrhea. And often thought about, the CT angiogram is the important step to make a diagnosis clearly. Pericardial tamponade is common in SLE, 30 to 35% cases, tamponade in 3.2. One of my patients has developed pericardial tamponade, and as pericardial aspiration was necessary. Response to corticosteroid with or without pericardial damage. Acute renal failure in rheumatology, it may be either a glomerulonephritis, interstitial nephritis, diffuse arteritis, or drugs. In summary, what are the lessons I have learned over a period of time? Rheumatoid, lupus, scleroderma constitute 75% of rheumatic disease admitted in ICU. Lung is the most common organ system affecting acute process, followed by kidney, GI tract, and central nervous system. More than 50% of admission result from infection, 25 to 35% result from flare. And about 20% cases of rheumatic disorder may be diagnosed for first time in ICU. Last part, most of the time internist is capable to deal with the emergencies rather than rheumatologist. Renal failure, coma, acute abdomen predict poor outcome and 50% die of infection. Besides conventional therapy, new therapeutic options, namely IVIG, plasmapheresis and rituximab, is a second-line treatment which has come up, and not particularly in case of lung disease, in case of patient who has got a gangrene. These are very useful steps to take to salvage the patient. Thank you for your courtesy, acknowledgement, Dr. Das, Dr. Vishwas, and others. Thank you very much. It is almost an internal medicine coverage, whole of it. And rheumatology, in fact, is internal medicine. Those who are good internists, they can be better rheumatologists.
Thank you,
Thank
sir.
you, sir. You have extensively covered all the rheumatological sets. All the rheumatological emergencies which internists may face in their hardest day, and they have to tackle with this. But due to paucity of time, one question or any comment is invited.
Just I am telling something to sir. When he has given this lecture, the lecture is most important thing, and you have seen in few minutes, within 20 minutes or 15 minutes, you have learned so many things. And I am thinking, when he was my external examiner, when we have heard during just before the Bhaiva, the sir is having the fascination for the rheumatology. We are imagining like this only. Because what he will ask, God is doing. But fortunately or unfortunately, he has not asked single question. They will be helpful for the patient, and the patient should be timely taken care by the person himself, or they should be suspected and then referred to a proper position. Thank you, sir.
Actually, timely decision is most important.
Exactly, sir.
In the rheumatological emergencies, as in the other discipline. And you have to take a decision. We have got limited drugs. We don't have angioplasty, so we have to depend on the chemotherapeutic agents and immunosuppressives to handle the situation. But infection remains the most important cause in our lifetime for rheumatological emergency, either to precipitate or to continue or even to land up in a crisis.
So for the next, I am inviting Dr. Hema Malusan from Chennai, and she will tell about the rheumatological manifestations of the systemic disease. And Madam is Senior Assistant Professor in Rheumatology, Stanley Medical College. And over to Madam, she will take that.
So, good evening, one and all. At the outset, I would like to thank the organizers for the wonderful opportunity. The topic given to me was to enumerate the rheumatological manifestation of systemic disease. Actually, it's a very vast topic. I'll just try to quickly take over you what are the manifestations of rheumatological thing we can have in a systemic disease. So I'll also project some case scenarios so that we can have a discussion also. So basically we know that rheumatological disorders have a lot of systemic involvement. On the contrary, systemic diseases also present with many of the rheumatological kind of complaints or symptoms or the history. So the musculoskeletal manifestations and autoimmune phenomena may develop during the course of the systemic disease also. Common histories or the common complaints as a rheumatologist, what we see was like the systemic disease can present as joint pain, they can present with muscle weakness, they can present as a manifestation of vasculitis, sometimes they can also present as a generalized pain. So again to tell you, so what are the systemic diseases which can have the varied musculoskeletal manifestation? Commonly what we see is only the endocrine disorders, commonly is hypothyroidism, diabetes mellitus, parathyroid disorders, necromegaly. In hematological disorders, hemoglobinopathies, hemochromatosis can also have musculoskeletal manifestation. Of course, malignancies can present as a rheumatological disorder also. So we need to be beware of the symptoms that are not suggestive of an inflammatory joint pain. Here I would like to suggest that people should know what is an inflammatory joint pain. So whenever you have a history of a pain which occurs after a period of rest or inactivity and then which disappears with activity, it is characteristic of an inflammatory joint pain. And of course the early morning stiffness should occur for more than half an hour. And the immunological positivity should be cautiously interpreted. See, normally when you see an ANA positivity or an ASO positivity or a CRH positivity, we generally think or we say that it's only a rheumatological disorder. It is not so. Because various other conditions can also have a CRP positivity or an RF positivity. Common thing what we see is only the RF and ANA to be positive, and many times it's referred to the rheumatologist. Because RF is not positive only in rheumatoid arthritis. It can be present in other illnesses also. It can be present in a chronic infection, it can be positive in tuberculosis, it can be positive in syphilis. So a lot of other chronic illnesses can also have a rheumatoid factor to be positive. And of course, in the general population, the rheumatoid can be positive around 5 to 10%, and again ANA can be positive in 5%. So the immunological positivity should be interpreted with caution. The patient who complains of joint pain, really it may not be the joint or arthritis alone. There could be a periarticular problem also. So to differentiate the articular problem, it will be a deep or a diffuse pain. You have the pain both during the active and the passive movements, and of course you have the other manifestation of inflammation like redness, erythema. Sometimes you can have joint instability, and very later they can go for the deformities also. Whereas a non-articular problem or a periarticular structure, it always causes a localized pain, and the pain will be mostly in the active movements but not on the passive movements. And of course you cannot see the inflammatory symptoms over the particular joint. Sometimes it may be away from the joint also. So you need to differentiate whenever a patient presents you the musculoskeletal pain, whether it's an articular problem or a non-articular problem. So, this is a history. Like a 42-year-old female who had a muscle pain and weakness for 6 months. She has an early morning stiffness lasting 10 minutes. CPK done was 380. The symptoms get worse at the end of the day, and she also has a significant fatigue. The examination reveals that she had a proximal muscle weakness, and she had a trigger finger, but there was no evidence of synovitis. And of course, she was found to have a bradycardia. So, what do you think here? Is it a rheumatological illness, or what would you like to suggest here? What could be the possibility of this? So much symptoms associated with this illness. Yeah, hypothyroidism. So rheumatological manifestations of thyroid disorders. Normally, hypo and hyper both have manifestation, but most commonly, hypothyroidism present with lot of manifestation. So arthralgias, myalgias, aches and stiffness, it behaves like a PMR like manifestations in hypothyroidism. And of course, a simple dose of your thyroxine over a period of time may resolve all these complaints. Arthritis, yes, patient can present with inflammatory polyarthropathy, typically associated with the gelling of the joints, and of course it also gets resolved when you treat a patient with thyroxine. Cutaneous, yes, sometimes you can see hypothyroid patient presenting with the Raynaud's phenomenon also. Normally you think, whenever you see a Raynaud's, you think in terms of vasculitis, but we also need to know the other causes of Raynaud's. Myopathy, yes, sometimes when the patient presents with the proximal muscle weakness, normally our intention is, as a rheumatologist, I used to think, okay, it should be an IAM, but it's not always. Hypothyroid can have a hypothyroid myopathy. And this carpal tunnel syndrome, it presents with varied disease like hypothyroidism, your hypoparathyroidism. A lot of other diseases have your carpal tunnel syndrome, as diabetes of course. carpal tunnel syndrome is also a common musculoskeletal manifestation of the systemic disease. Vasculitis as such is not observed much in hypothyroidism. Rarely it can be seen in hyperthyroidism when you treat the patient with profile diuresis. And ANA positivity, as I said earlier, normally a hypothyroid patient will have an ANA positive. But when you do an ANA profile or an ENA profile, the other antigens may be negative. So that ANA positivity in a hypothyroid patient should be taken with a pinch of salt, because hypothyroidism is also most commonly associated with other rheumatological illness, like your commonly with systemic lupus erythematosus. Of course, some patients also have a rheumatoid. So hypothyroidism, whenever a patient has hypothyroidism, you should take it with a pinch of salt, because the patient may develop autoimmune disorder in later part of life also. So that's about thyroid disorders. And this is another history. This is a 66-year-old lady who had paresthesia in the hands, and she had stiffness in the joints for past 3 years. She cannot straighten her fingers, and you can see the figure here. She has hypertension, and she's a diabetic for 15 years in medical treatment. RF is positive, CBC, ESR and CRP is normal. So what is it? Yeah, this is a prayer sign. This is diabetic keratopathy. So it is not like, see, when you see an RF to be positive, you may not think this is only going to be a rheumatoid arthritis, because diabetes can also present with varied manifestation. So these are the rheumatological manifestations of diabetes. Patient can present with adhesive capsulitis. Normally they present with the shoulder joint pain. And normally we think it is a shoulder arthritis, but it is not so. It is a periarticular structure which is involved in diabetes. They can have a shoulder joint pain. A simple clinical examination like asking the patient to do an extension or abduction will tell you that the patient has got a periarticular involvement. And limited joint mobility, which I showed you, is a prayer sign. These manifestations are because of the deposition of advanced N-glycosylation products in the like your tendons or the fascia. That's the reason why you have this manifestation. Dupuytren's contractures. You can have a tenosynovitis. Many times we see tenosynovitis as a predominant manifestation, and of course we do evaluate these patients for rheumatoid arthritis also. Carpal tunnel syndrome, as I said earlier, and calcific tendinitis, yes, it can occur in diabetes mellitus too. And DISH. There is a many times when you see a patient X-ray with ossifications or a calcification, we think either it should be a spondyloarthropathy or it's a DISH or some other thing. So there are certain characteristic features that differentiate whether it is spondyloarthropathy or a DISH. Normally DISH occurs after an age of 50, and of course you don't have the involvement of the sacroiliac joint, and the intervertebral disc phase will be very well maintained in DISH, but not in spondyloarthropathy. And Charcot's arthropathy, yes, you all know. And muscle infarctions, patient can present with muscle infarctions. And the stiff person syndrome, you have the paraspinal ligament calcification. So you have the stiffness in the back, and the patient will have a severe pain in the entire paraspinal region. Normally it is associated with the anti-GAD antibodies. So this is another sign in diabetes, that is a tabletop sign, which is a similar thing to a prayer sign. So, just to enumerate the musculoskeletal features of acromegaly, here again, the main thing is because of the increase in the growth hormone and the IGF-1, you have cartilage thickening, and you have got lot of ligament calcification. So, and of course you have effect over the bone also. So, you can have like large bone, the remodeled shafts, or thick cartilages, enlarged tendon, and you can also see marginal osteophytes. And frequently, patient doesn't go for severe restriction because the mobilities, even though they have the cartilage thickening, they don't go for the restriction of movements. The spinal mobility is maintained. So these are all the radiological findings. You can see like tufting of the, I'll show you the figure actually. So you can see a soft tissue, thickening here, and you can see the epiphysis being squaring of the epiphysis and other things. Just to enumerate the radiological findings. This is a lumbar spine appearance in the acromegaly, where you can see the increased joint space. Here you can see the increased joint space and other things. And coming to the next systemic disease, the parathyroid, both hyper and hypoparathyroidism have effect over the bone, because we know that parathyroid hormone has a lot of effect over the calcium homeostasis and also over the bone metabolism. So normally hyperparathyroidism, they present with arthralgias, they can have arthritis, particularly the small joints of the hand, but only differentiating factors between the hyperparathyroidism and the rheumatoid arthritis is here we don't have RF to be positive. Your inflammatory markers may not be elevated in hyperparathyroidism, and of course I think the PAP joints also will not be involved in hyperparathyroidism. We have the involvement of the radiocarpal, inferior radial and MCP joints. and brown tumor, you all know, and both in hyper and hypoparathyroidism that can present as gout-like features because there is increased uric acid and also calcium CPPD, crystal phosphate deposition can also occur in both hyper and hypoparathyroidism. So these are some of the radiological findings you can have in classical hyperparathyroidism. The typical thing is a periosteal resorption which you see in the X-rays. And this is a skull, salt and pepper, the skull, and this is mandible which shows a bone cyst here. So coming to the other things, hemochromatosis. Hemochromatosis again can have a non-inflammatory arthropathy, and the typical joint which is the thing which is involved is the second and the third MCP joint, which is called as a handshake sign. In the X-ray you can see there's hook-like manifestations in the X-rays, and of course PAP joint, knee, wrist and distal ulnar, radial ulnar joints can also be involved. And again in hemochromatosis there's more chance of chondrocalcinosis of the knee, wrist and spine. And hemophilia, normally when you see a monoarthritis, it is mandatory that either you have to do an imaging or put in a needle, aspirate the joint, because there are a lot of differential diagnoses for a monoarthritis. One among the differentials could be a hemophilic arthropathy. Other things could be a septic arthritis or a tuberculous arthritis. So monoarthritis should be always intraarticular aspiration has to be done whenever you see a case of monoarthritis because it could be even a blood into the joint. So acute hemorrhagitis, a child can present with a swollen, warm and painful joint. Sometimes we used to think this is a case of JEA, but it's not always. So mainly it affects the larger joints. And chronic hemophilic arthropathies has definitely effect over the bone. It causes loss of deformities, and there is increased incidence of septic arthritis and a hemophilic arthropathy also. So you need to aspirate the joint and you need to know what is it exactly. And sickle cell disease, again present with varied musculoskeletal manifestation. The common thing is dactylitis. Dactylitis, you have got a lot of causes of dactylitis. Sickle cell disease is one of the reasons for a dactylitis. It can be like bone infarction. The common thing is avian in the joints and vertebral collapse, and then they lead on to the secondary osteoarthritis. And osteomyelitis also occurs in sickle cell disease, and you have the sickle cell bone crisis where you have bone pain, fever and localized swelling and erythema. So you need to know this manifestation to know like what is the underlying disease which is causing all these manifestations. So this is just images to tell you, like you have the involvement of the MCP joints with the, MCP joints are involved here, and you can see the hooking sometimes, and here you can see. And this is a chondrocalcinosis of the wrist joint. So this is a hemophilic arthropathy. Typically, you can see the epiphysis ballooning, and here you can see a lot of bone cysts into the joints. These are all hemophilic arthropathies. And this is typical of your sickle cell disease, where you can see avian in the hip joints. So coming to the next systemic disease is sarcoidosis. So normally, when a patient presents with an ankle arthritis, and if he has an associated erythema nodosum, then there's a high chance that the patient may have a sarcoidosis. That is called as a Lofgren syndrome, where you have erythema nodosum, ankle arthritis and hyaluronidopathies. So acute arthritis, it can present as acute polyarthritis, that is Lofgren syndrome, or it can also present as a chronic arthritis. But for us to see as an initial musculoskeletal manifestation is not that common, though they come with various other manifestations also. But I have seen few cases where they have presented only with ankle joint pain and later evaluation turned to be a sarcoidosis also. And the second thing is myopathies. They can present with myositis. They can present with acute myositis or chronic myopathies. And the common myositis there we have is a nodular, because it's a granulomatous myositis where you have in those patients. So these are the musculoskeletal manifestations of sarcoidosis. And yes, amyloid also can, as a rheumatologist, I see amyloid as a complication of heart disease, like long-standing rheumatoid arthritis, long-standing JAA, or long-standing psoriatic arthritis. When they develop a proteinuria, we suspect an amyloid and we do a renal biopsy and we diagnose the disease. But on the contrary, primary amyloidosis can also have a musculoskeletal manifestation, commonly with ATR amyloid and AL amyloid. The common symptoms could be a carpal tunnel syndrome, spinal stenosis, muscle weakness, arthropathies, pseudo-hypertrophy of the, I think it's called as poppy sign, pseudo-hypertrophy of the muscle, sometimes soft tissue swelling of the shoulder pad and jaw claudication. These are the musculoskeletal manifestation of amyloid. Here, this is a 68-year-old lady who was admitted with a digital discoloration. You can very well obviously see a gangrene. She was a smoker and a Hep B positive. What do you suspect here? Is it a primary vasculitis or it should be some other way? No. It could be a cryognomic vasculitis associated with HPV infection. I'll just finish it. So commonly you see with associated HCV, but you can also get in association with HBV also. So vasculitis, always it is not only because of primary vasculitis. You've got a lot of other vasculitis mimics also, so you need to consider those things. Like malignancy can present as a paraneoplastic vasculitis, and a lot of infection can also present as vasculitis. And finally, 2 slides, rheumatic paraneoplastic syndrome. Malignancies can present as a arthritis. So you have paraneoplastic arthritis. So whenever there is an arthritis not responding to routine steroids and immunomodulatory therapy, then you should think that there's something else underlying in the patient. So paraneoplastic arthritis can present a similar manifestation. Palmar fasciitis and polyarthritis syndrome, which occurs in your solid tumor malignancies. And RSP3 like manifestation, erythromelalgia, paraneoplastic vasculitis, cancer-associated myositis. Yes, many of the dermatomyositis patients, when the onset is very late, like after 60, always you have to suspect CA underlying them, ideally a PET or the myositis profile can help in this patient because P55, TIF and TXP2 can be present in this patient. And HPOA, yes, of course, can present in a paraneoplastic form, and tumor-induced reduced osteomalacia. Yes. So the approach to the patient should be like whenever they present the joint pain, if it is a single joint, aspirated joint, and if this is tendinitis associated, just consider doing other investigations like your routine blood glucose estimation and thyroid function test also. Whenever you see a patient presenting with vasculitis, just get cultures done, analysis, urine analysis, simple urine analysis, Hep B, Hep C serologies, and of course a 2D echo because to rule out an infective endocarditis also. When the patient presents a muscle weakness, just get a muscle, apart from the muscle enzyme, thyroid function, EMG and biopsy will tell you what is the underlying etiology for the muscle weakness. And generalized pain, we always hear that term like groan, moan. So hyperparathyroidism should always be thought whenever a patient presents with a generalized body pain. So calcium, vitamin D and thyroid function should be done in those patients. The summary is systemic disease can present with varied rheumatological manifestations. So open mind and a high index of suspicion is essential to diagnose it because the treatment protocol significantly varies in both the disorders. Thank you. Thank you.
As rheumatologists or as physicians or clinicians, when we treat rheumatic chronic rheumatic diseases, the most important problem which we are likely to encounter is infections. Infections and infections, especially in countries like ours. This is a very, very important problem. This increased prevalence of infection may be due to inherent immunosuppressed state related to the disease, or it may be due to the immunosuppressive agents which we are using for the treatment, or it may be related to the comorbidities. But whatever be the cause, infections cause is an important, significant cause for morbidity and mortality in chronic rheumatic diseases. Not only acute infections, chronic and opportunistic infections also are very common in rheumatic diseases. People have looked at why there is increased prevalence of infection, and they found that older the age, higher disease activity, high disability score, comorbidities like chronic lung disease or kidney disease, and especially glucocorticoid treatment, history of previous serious infections, current immunosuppressive therapies, and history of previous DMARD failures, all these contribute to the development of infections. To summarize, the risk of infection is highest when the patient is highly inflamed, very much immunosuppressed, and possesses multiple comorbidities, or is taking high dose of steroids. Now, whenever your patient who is on treatment develops an infection, once he improves, or if he doesn't improve, the one question which we can anticipate from the patient or the bystanders is whether these infections are due to the medicines which I have been taking, sir. So let us look at the relationship between infections and the drugs. In chronic rheumatic diseases, the most important group of drugs which we take is disease-modifying anti-rheumatic drugs. Of the conventional DMARDs, hydroxychloroquine and sulfasalazine are not associated with an increased risk of infection. They are very safe and can be continued when there is an infection. Regarding methotrexate, there was discussion in previous talks. Methotrexate may increase the general infection risk slightly, but it has a favorable safety profile for serious infections. So that also is not a bad drug in patients with rheumatic diseases. Even combination DMARD therapy generally is safe and well tolerated. So regarding methotrexate, what I can say is for mild infections and those undergoing low risk elective surgeries, methotrexate can be continued. But for moderate and severe infections requiring antibiotic treatment and hospitalization, it is always better to withhold methotrexate till the patient recovers from the infection. It may be 1 or 2 weeks, but it is better to stop the medicine till the patient improves. Among the various other drugs, steroids are the most important drugs which can precipitate infection. Glucocorticoids cause a dose-dependent increase in the risk of serious infections. And even the so-called low-dose daily steroids are frequently considered as safe, but long-term continuous exposure even to low-dose steroids can increase the risk of infection. Now the infection problems became more significant with the introduction of the biological DMARDs. Incidence of serious infections in biological DMARDs treated rheumatoid arthritis patients ranges between 3 to 7 per 100 patient years. This risk appears to be maximum in the first year of treatment. And patients who develop a serious infection, there is a 3 to 5-fold increase in the risk of a subsequent infection. And even chronic infections like tuberculosis became more prominent with the introduction of biological DMARDs. And in the last decade, the magic molecule, JAK inhibitors have been introduced, baricitinib, tofacitinib, and upadacitinib. All these drugs are very effective and have become very popular in a short span. The rate of serious infection is similar to biological DMARDs only. There is no major difference between the JAK inhibitors regarding infection of the 3 available ones. And even post-marketing data for tofacitinib did not show much increased risk for serious infections, but a recent randomized control trial showed that there is an increased risk for infection, especially in patients who have got cardiovascular risk factors, and this risk is more when the age is above 65. So we have to be more careful when we use these drugs in patients who are elderly and have got cardiovascular risk factors. Now let us look at what are the important infections which are seen in rheumatic diseases. Non-serious infectious events are very common in patients with chronic rheumatic diseases, just like in general population, and it may not have much impact on the patient's overall outcome. But see, when it becomes serious infections, it is a problem. So there is an increased prevalence of acute serious infections in chronic rheumatic diseases. The organs involved may be lungs, urinary tract, skin, or even joints. These are the commonly affected joints. And the organisms also are same as in general population. The serious infections are 1.5 to 7 per 100 patient years. The major culprits are corticosteroids and biologics, which are more associated with infection rather than the conventional disease-modifying drugs which we have been using in for a long time. The risk factors, as we have already mentioned, and people have looked at what is the risk of developing a serious infection in patients who are taking biological therapy compared to conventional DMARDs, and they found that the risk was increased by 30% in patients who are taking biological drugs. And serious infections are an important problem in patients with lupus. We know that 20 to 30% of death in lupus is caused by infections. The rate of serious infections in lupus is 5 times higher than in rheumatoid arthritis patients. And this is 12 times higher than RA patients in patients who are taking treatment for lupus nephritis. The important infections are pneumonia, urinary infections, sepsis, and skin infections. And drugs which we use, azathioprine, mycophenolate, cyclophosphamide, increase the risk of infection by 10%, whereas steroids increase the risk by 50%. Whereas hydroxychloroquine has got a protective factor, it decreases the risk by 30% in lupus and 20% in lupus nephritis patients. Therefore, in the setting of a serious infection, we can continue hydroxychloroquine and sulfasalazine. Methotrexate and leflunomide may confer small or no increased risk, but steroids and biologicals may be withheld during acute infection. Now, after serious infection, the other important infection which we come across is tuberculosis. And tuberculosis has become a major problem after the introduction of biologicals also. The steroids and biological agents and JAK inhibitors all predispose to tuberculosis. And they actually cause reactivation of tuberculosis in patients with undiagnosed underlying latent TB infection. So all patients in whom you are planning to start biologics should be screened for active or latent tuberculosis. You should do a screening using a tuberculin skin test or interferon gamma related assays, IGRAS or both. So if you are doing both the tests, you should do them simultaneously. And to rule out active tuberculosis, you should always take a chest X-ray also, PAV also. So all patients who are found positive for either TST or IGRA should be treated for latent tuberculosis. The currently suggested regimes are INH 300 isoniazid 300 mg per day for 6 months, or rifampicin 600 mg per day for 4 months, or the combination of INH and rifampicin for 3 months. And actually this treatment of latent tuberculosis had led to a substantial decrease of newly diagnosed tuberculosis cases in patients taking biologicals. So biologic agents can be initiated, patient if he needs biological agents, it can be initiated or assumed after 1 month of latent tuberculosis treatment, after starting one month after starting treatment. And in patients with active tuberculosis, if it is not very important, we can wait till the completion of the treatment of active tuberculosis, or at least wait for the intensive phase of 2 months to complete. Now, another common infection which we encounter is herpes zoster. Rheumatic patients on treatment have twofold higher risk for developing herpes zoster compared to general population. And methotrexate and JAK inhibitors are the main culprits. Herpes zoster is not very common in patients with biological DMARDs or in patients with other conventional disease-modifying anti-rheumatic drugs. And in an analysis of 44 studies with JAK inhibitors, they found that herpes zoster occurred in 2.1 of 100 patient years among JAK inhibitors compared to 1.23 in the comparator group. So there is no difference between the 3 JAK inhibitors as far as herpes zoster incidence is concerned. So in long-term studies, it has been shown that 11% of patients on tafasitamab develops herpes zoster. Luckily, most of the herpes zoster cases are very minor type, like non-serious involvement, and there is very low incidence of post-herpetic neuralgia. Among the patients who continued JAK inhibitors, 9% had a second episode of herpes zoster also. And patients with herpes zoster should be treated with oral antivirals started within 72 hours of rash onset. If the patient is on methotrexate, it may be stopped for 10 days. Now, another important infection is hepatitis B. Reactivation of hepatitis B can occur during immunosuppressive therapy for rheumatic diseases. The reactivation is usually characterized by an increase in the hepatitis B virus DNA level more than 10-fold, or an increase in SGPT more than 2-fold. A glucocorticoid dose more than 20 mg for more than 2 weeks can induce immunosuppression and produce reactivation of hepatitis B. So typically, before you start drugs like biologics, we should screen these patients for hepatitis B status. And the typical screening include HBs antigen, anti-HB core antibody, and anti-HBs antibody. And in a patient with acute hepatitis B infection, glucocorticoid should be immediately stopped. Non-biological DMARDs are relatively safe in patients with a low risk of reactivation, but it is better to stop methotrexate, leflunomide, and azacitidine. Regarding biological DMARDs, risk of reactivation increases during anti-TNF therapy in patients with HBsAg positive patients, and in patients with undetectable HBV DNA level, anti-TNF agents can be given. The ACR guidelines do not recommend anti-TNF therapy in pharmacologically untreated hepatitis B patients. And rituximab especially has got a high risk of reactivation. So we should not give rituximab in patients who are positive for hepatitis B. The risk is more if steroids are given along with. And treatment of hepatitis B, we have effective treatment. So we can treat with tenofovir or entecavir in acute carriers with high HBV DNA levels, and lamivudine for inactive or hidden carriers. Now, hepatitis C is another infection which we may encounter in patients with chronic rheumatic diseases. It's a global problem affecting 180 million population, and as you know, transmission is by parental route. We have to screen them for anti-HCV antibodies, and if these are present, we should measure the HCV RNA levels also. So if the patient is HCV positive, we should avoid hepatotoxic drugs. Hydroxychloroquine and sulfasalazine are safe. And anti-TNFs have been found to be relatively safe in hepatitis C virus infection. In fact, etanercept actually enhances interferon-based antiviral therapy, and rituximab is a safe option in patients with chronic HCV infection and cryoglobulinemia. Safety of other medicines like mycophenolate mofetil, cephalosporin, azathioprine are not studied properly. This is just to show the algorithm of hepatitis C. As you can see, if the patient has got HCV positive and there is rheumatoid arthritis, there is no cryoglobulin, and in such cases we can give hydroxychloroquine, anti-TNF alpha, anti-CD20, rituximab, low-dose steroid, DMARDs. These are usually given along with the antiviral therapy. Similarly, HCV-related arthritis also we can try hydroxychloroquine, low-dose steroid, anti-CD20, interferon alpha with ribavirin, and the other disease-modifying drugs. For cryoglobulinemia, rituximab is the treatment of choice. Now, COVID-19 infection pandemic is gradually fading away. Our rheumatic patients on treatment, all of them did fairly well during the pandemic. The risk of mortality was comparable to the general population, like other risk factors like older age, etc. So the treatment did not produce much problems. Regarding the anti-rheumatic medications while on COVID, all the drugs were used as previously during the pandemic. But when the patient develops infection, steroids at low dose was recommended. In fact, that was the main treatment which we have given. And it was advised to stop other disease-modifying drugs also during the acute infection. After that, the medicines were restarted. Regarding HIV infection, NSAIDs, indomethacin is the NSAID of choice if it is needed. Sulfasalazine, hydroxychloroquine, all are effective. Methotrexate, initially thought as contraindicated, but can be used with careful monitoring. Hydroxychloroquine can be used safely. It has got antiretroviral activities also. And even anti-TNF agents are safe in patients with HIV infection who are resistant to conventional DMARDs. We had a very exhaustive discussion on vaccinations. Now to conclude, always be on the lookout for infections while treating rheumatic diseases. Conventional DMARDs, hydroxychloroquine and sulfasalazine are very safe in the setting of infection. Methotrexate, leflunomide may be stopped temporarily during serious infections. Tuberculosis is a main concern while using biologicals. Always screen for latent tuberculosis before initiating biologics. Hepatitis B and C should be screened before initiating immunosuppressives. Herpes zoster is a frequently encountered problem while treating rheumatic diseases. Vaccinations are very helpful to prevent infections. Thank you for the patient listening.
Thank you, Dr. Jayachandran, for your descriptive lecture. And it is one of the lectures which we as a physician always like. And
when they develop some stress, if they are on chronic steroid therapy, it is better to maintain them on a small dose. I agree with you.
Answer a few queries at the end of the session. So, without much ado, we will go to the topic. It is managing rheumatic diseases during perioperative period. So, what are the preoperative considerations that we are supposed to look in a patient with these autoimmune rheumatic diseases, especially in patients who have rheumatoid arthritis, spondyloarthritis, and lupus? So, one is, it depends, one is the patient's age. What are the comorbidities, that means especially the cardiovascular system as well as the respiratory system status of the patient? How long has he been suffering from rheumatic diseases? What are the comorbidities he has? Did he have any previous complication to the surgery when he had undergone surgery earlier? Then we look at the various medications which may hamper the healing in the post-operative period. And then along with that, what again decides on the outcome of surgery is the current disease activity and functional status, and some of the deformities which patient have, which may have some implication on anesthesia and further recovery. So we'll go to first how we, when a patient is taken up for surgery, there are, first of all, the patient has to clear the anesthesia, pre-anesthetic checkup, and there are a lot of things we have to look at whether the patient is fit enough to undergo anesthesia. So the first in rheumatoid arthritis, the major concern is if there is a, this is generally now not seen so much because of a very good control of RA in common clinical practice. But however, if a patient has neck pain, you definitely have to look at if they have any evidences of atlantoaxial dislocation, cervical spine instability, any subluxations, because that can lead on to a difficult intubation, and sometimes the manipulation of unstable cervical spine can result in spinal cord injury or death. Then another important thing which has to be looked at from anesthesia perspective is basically the cricoarytenoid joint arthritis. So a significant cricoarytenoid arthritis and the arthritis of temporomandibular joints can actually lead on to difficult intubation again in these patients. So that has to be looked at. And also sometimes the trauma during intubation can lead on to severe edema, airway obstruction. This is associated with all these cricoarytenoid joint arthritis can ultimately lead on to a difficult post-operative period. Another consideration in relation to the cervical spine only is in ankylosing spondylitis. Again, two things are there in an advanced ankylosing. The first I will put is severe osteoporosis, and second thing, because the spine is not mobile as well as osteoporotic, there are increased chances of fracture during manipulation of the spine. So that is why we are very concerned in advanced AS patients before they are taken up for surgery, and you have to kind of make the anesthetist as well as the surgeon aware of all these things before the patient is taken up for surgery. Second, another thing other than the spine per se, now we come to the cardiopulmonary disease. So definitely rheumatoid arthritis, lupus, as well as nowadays spondyloarthritis. All these three conditions have an increased risk of cardiovascular disease. So they have increased risk of ischemic heart disease, they have increased risk of atherosclerosis and future cardiovascular events like myocardial infarction. So that is why actually you have to be aware that these patients have to be addressed properly, and you have to go one step more than what you go for a routine patient to during the perioperative assessment to look for any cardiovascular disease. Then the next one, the slide is moving by itself. Are you moving it? No? Okay. Okay. It's just moving by itself. Okay, fine. Then the next is the cardiopulmonary disease. So again, you should have a high index of suspicion. Then sometimes just the patient, the history of the patient, as well as what we do about cardiovascular assessment is basically we cannot follow the traditional risk algorithms like Framingham risk algorithm and things like that when you deal with rheumatoid arthritis patients and spondyloarthritis patients, because of an inherently increased component of disease activity leading on to cardiopulmonary disease in these patients. So you have to probably, you can't just be okay with echo or ECG for these patients. You probably will have to include something like stress tests, post-operative troponin screening, etc. to identify any subclinical cardiac events before you get a major problem. Another important thing about cardiopulmonary disease status is the interstitial lung disease. Rheumatoid arthritis, as most of you may have encountered, is associated with ILD. Now it is even in early stages of disease and sometimes before even the onset of the clinically arthritic symptoms. So that is why interstitial lung disease is very important. It's a very important thing to look for before the patient is undergoing any surgery. Another important thing is pulmonary artery hypertension. That is predominantly in lupus patients or in patients with mixed connective tissue disease and sclerosis. Pulmonary artery hypertension, we all know pulmonary hypertension as such. It can be very fatal in perioperative context, and especially the patient is getting anesthetic drugs, which is again leading on to a lot of vasoconstriction and cardiovascular issues. So you have to make the surgeon as well as you have to be involved in the care of these patients if they have PH. Okay, so how do we deal with all these things? I think I have just taken you through during when we were discussing. So the problems. One thing which is very important is that you have to go one step extra to assess the cardiopulmonary status. Sometimes the cervical spine radiographs may be advisable, especially if the patient has advanced rheumatoid arthritis or has uncontrolled rheumatoid arthritis or has any evidence of neck pain. Then echo and this thallium scintigraphy is required on case-to-case basis. Pulmonary function test if the patient has interstitial lung disease. Yet another problem which is seen in rheumatic disease patients is the venous thromboembolism. Now, venous thromboembolism, we all know, it can be, one is because of the disease per se, and the other one is attributable to treatment, like somebody, just the previous speaker had alluded to use of tofacitinib, is associated with increased risk of thromboembolism. And other than that, all the systemic inflammatory diseases, they have an increased risk of pulmonary embolism and venous thromboembolism, with special reference to patients with lupus and APS. So that is why sometimes in a patient with APS, it is very important for you to formulate a plan so that the patient's risk of thrombosis is decreased. Because always a intraoperative period as well as a post-operative period, there is always an inherent risk of thrombosis. So that is why you have to be very careful when you are minimizing the anticoagulation, because always these patients, most of these patients who are anticoagulation cannot be taken up for surgery. So generally we convert them onto heparin and then skip one dose of heparin and then they send the patient for surgery. But sometimes the skipping of one dose can be very deleterious. So you have to be, like, everything has to be weighed before the patient is taken up for surgery. Now, there are, I'll probably skip this because there are a lot of some surgeries, they require tweaking of and stopping of these anticoagulation because of high bleeding risk. So these are the major organ surgeries, whereas the minor surgeries like a minor dental procedure, tooth extraction, minor dermatological procedure, like if you just want to do excision biopsy, or excision or minor ophthalmic procedures like cataract extraction, phacoemulsion. So these have low bleeding risk. So you can actually, case to case, you can decide whether you would like to completely stop anticoagulation or would like to continue. For example, if a patient has a very high risk of arterial thrombosis and is undergoing a minor dental procedure, then it will be very deleterious for you to stop the therapy, stop anticoagulation before you send the patient for these procedures. So these are the basically, anesthesia. This American Society of Regional Anesthesia had put up certain guidelines for how to titrate these anticoagulants during the perioperative period. So they recommend use of these vitamin K antagonists. Vitamin K dependent antagonists, that is your discontinue warfarin at least 5 days before surgery. And then you have to start subcut low molecular weight heparin or unfractionated heparin depending on the renal status of the patient. 2 days before the surgery, you assess INR, make sure that INR is less than 1.5. It's not that you have to give vitamin K. And then 24 hours before the surgery, you have to discontinue low molecular weight heparin. And if it is unfractionated heparin, 4 to 6 hours before surgery is good enough. That means basically skip one dose. What happens during post-operative period? A post-operative period as such is a high risk for thromboembolic events. So if the patient has underwent only a minor surgical procedure, you can resume the heparin 24 hours after the surgery. But if it's a major surgical procedure, you may have to wait for 48 to 72 hours depending on the surgery. Then you can start heparin 12 to 24 hours after surgery if it's a minor surgery and there is no unexpected surgical bleeding. Always assess the bleeding risk and adequacy of hemostasis before the resumption of heparin, either low molecular weight or unfractionated heparin. Now moving to what is the chance of patient developing infection? As again, all the patients, especially rheumatoid arthritis, lupus, and to an extent spondyloarthritis patients, all of them have increased susceptibility to infection. Lupus per se, rheumatoid arthritis per se are the diseases which increase susceptibility to infection. On top of that, you are killing the immune system of these patients. So definitely infection becomes a high risk during the perioperative period. So there was a large cohort of patients with lupus wherein they found that higher rates of septicemia and pneumonia are seen in these patients even if they are not on immunosuppression. I don't know, it's the computer is behaving in a funny way. So sometimes people, some researchers have recommended that you do something called as perioperative decolonization of patient with rheumatoid arthritis if they are on biologics. But I do not know how much it's practical and whether it is valid in our patients who are anyway, they are anyway exposed to high risk of infections, and this perioperative decolonization, I'm not very sure whether it holds good. So there are some decolonization protocols, like you have bacterial ointment, chlorhexidine shower bath, all those things are there. And especially in patients who have the skin issues. For example, if they have ulcers, if they have psoriatic skin lesions, because they are the ones who are highly susceptible for MRSA and related infections. So you have to be careful in these patients. Prophylactic antibiotics are advisable, I must say, for patients of rheumatoid arthritis wherein they are undergoing very long procedures, like you have total knee replacement, prosthetic joint surgery, etc. We generally do not follow prophylactic antibiotic except for Septran. If a patient is on high dose immunosuppression, we like to give patient on Septran, and it possibly helps. However, the surgeons, they always would want to have a prophylactic antibiotic at least 5 days before the surgery. Alright, so what is your goal? The goal is you minimize the risk of infection, you minimize the risk of delayed wound healing. However, you have to balance that the patient should not have a disease flare or any resultant threat during the post-operative rehabilitation. That is the goal. So how do we manage the DMARDs and glucocorticoid therapy perioperatively in these patients? First and the foremost fear of any surgeon is glucocorticoids. So how do you manage glucocorticoids? Glucocorticoids have actually been shown definitely to increase the rates of infections and wound healing complications in various studies. And not just that they are associated with increased risk, it is a dose-dependent increase. So if you give even 5 to 10 milligram per day, which we generally consider as low-dose glucocorticoids, they also are associated with significantly increased risk of infection. Can we stop them? That depends on whether the patient, how long is the patient is on steroids, and what is the disease activity status. So you have to optimize glucocorticoid dosing as less as possible. That is the dictum. Now, if the patient is, can I take 5 minutes? Is it okay? So if the patient is undergoing knee or hip replacement or receiving glucocorticoids, surgery is conditionally recommended. During the surgery, earlier we used to give supraphysiologic doses, but nowadays it is advisable to continue just the daily dose of steroid rather than going to the so-called stress protocol. But if there are very prolonged surgeries which are requiring quite a long period of time, then maybe additional glucocorticoids may be required. So I'll skip this. Now regarding, I think in the interest of time, I would just straight away come to the DMARD. So the American College of Rheumatology has actually put up a guideline on when to stop, whether to stop the conventional and biologic DMARDs, and if yes, when to stop. So the rule of for the conventional synthetic DMARDs, basically Nowadays, if the patient is undergoing an elective surgery, then you can continue methotrexate, sulfasalazine, HCQ, leflunomide, and doxycycline unchanged during the operative period. What about the biologics? The rule of thumb is that you stop biologics, you skip one dose. So whenever you are giving one dose, you have to skip. So for rituximab, generally you have to skip one dose of rituximab. So that implies that you have to stop rituximab 7 months prior to surgery, because the next dose will be after 6 months. So that dose, for you to skip that dose, you have to basically have given rituximab 7 months prior. So for every drug, however, how you give the drug, basically you have to skip one dose of drug before you take up the patient for surgery. That is the rule of thumb for biologics. What about the cytotoxics, that is mycophenolate, azaran, cyclosporin, tacrolimus? If need be, you can continue it during perioperative period, except on conditions on patients who are again requiring, you think the surgical period is going to, the surgery is going to be prolonged than 4 to 5 hours. So another thing is that there is a risk of gouty flare, so you have to keep that in mind. There is special precaution for patients with Raynaud's phenomenon, and also hypothermia must be avoided post-operatively for these patients, because these patients can go in for gangrene. So I think I'll stop with this, and just to reiterate that these slides were actually given by Dr. Rajesh.
Thank you, Dr. Ruchika Madam, for such a long known case of SLE comes to rheumatology OPD, and with tender joint count of 10, swollen joint count of 8. She wants to understand regarding choice of contraception and if it is safe to plan pregnancy.
So here, first we should assess how is the disease. So for planning any pregnancy like this, disease should be at least inactive for 6 months, especially for lupus. Along with that, we should also assess if there is any history of thrombosis or any previous history of abortion or something like that. Apart from that, other findings which are the absolute contraindication, like severe renal failure, severe PAH, and severe heart failure, in which the pregnancy would be fatal for the patient. Then the patient has to be counseled not to plan about it. Now coming to the contraception part, so intrauterine devices are safe in all cases of lupus, except if it's contraindicated by the gynecological point of view. Apart from that, if we come to the hormonal therapy, so combined, if the patient of lupus is APLA antibodies negative, and along with that the disease is inactive, then combined hormonal therapy can be planned, but still there can be a risk of thrombosis, which has to be weighed against it. And if the APL is positive, then obviously you can only try for progestin hormonal therapy. And along with that, they should also be advised ecosprin to be taken with that.
So, Dr. Raja, what conventional demands are safe in pregnancy in patients with rheumatoid arthritis?
So as we all know, the conventional demands are 4: hydroxychloroquine, methotrexate, sulfasalazine, and leflunomide. In pregnancy, only 2 of these drugs are approved: hydroxychloroquine and sulfasalazine. Methotrexate and leflunomide are not recommended during pregnancy. And hydroxychloroquine, the dose is less than 400 mg per day. And sulfasalazine, you can administer during pregnancy, but you must remember that you must give folic acid supplementation in the first trimester. So many times we see sulfasalazine is given during the pregnancy, but folic acid supplementation is not given. So in the first trimester, you should supplement folic acid along with sulfasalazine.
Now the next one to Dr. Sweto. A 30-year-old rheumatoid arthritis on methotrexate and leflunomide comes to your OPD for regular follow-up, and she had a last menstrual period 8 weeks ago. How would you proceed with this now?
So here, last menstrual period was 8 weeks back. So firstly, we should stop all the medications. Folic acid should be continued. Along with that, as she was already on leflunomide also. So cholesterol washout should be advised at this point. Meanwhile, you confirm the pregnancy. Once the pregnancy is confirmed, then patient has to be counseled in detail regarding the fetal risk of the due to side effects of methotrexate and leflunomide. And they should be referred early to the fetal medicine department so that they can do the anomaly scan and decision can be taken hence on. And if if patient is planning pregnancy, then methotrexate has to be stopped 1 month prior, which is according to new BSR guidelines. But in EULAR and ACR still recommends 3 months stopping for that.
And what about leflunomide?
Leflunomide, ideally, if the patient is in a childbearing age, at that time leflunomide should not be used because the time period that has been discussed is around 2 years. So that becomes very difficult.
That's extremely important because, as you know, many orthopedic surgeons and physicians also treat rheumatoid and they give leflunomide, sometimes without knowledge, and this should not be given during pregnancy. And if somebody is on leflunomide, make sure you give a cholesterol washout, otherwise there are legal implications. So if somebody is on leflunomide, knowing you are unknowingly, it must be given a washout if they are pregnant. Now the next question, we use a lot of painkillers, non-steroidals during pregnancy, lactation. Dr. Raja, please tell us what is safe.
Yeah. So this is a common scenario. It's not only rheumatoid arthritis, any pregnant patient can come to our clinic and have pain. So can we give non-steroidal anti-inflammatory drugs? The point is you debate whether it is a COX-2 or a non-selective NSAIDs. COX-2 inhibitors, that is celecoxib, etoricoxib, all are not recommended because we don't have enough safety data to say whether they can be used in pregnancy or. So what is left is non-selective NSAIDs. So what is the problem of using non-selective NSAIDs in the first trimester? In the first trimester, there is a risk of miscarriage, but it's not huge. So you can use NSAIDs intermittently in the first trimester, as and when needed. But when used in the later part of pregnancy, there is a chance of closure of ductus arteriosus, we all know. So better you don't give NSAIDs more than 30 weeks of age, unless it's absolutely indicated. So generally, in first trimester, we can use non-steroidal anti-inflammatory drugs intermittently. At the later part of pregnancy, do not give non-steroidal anti-inflammatory drugs. In lactation, NSAIDs are safe. And the safest NSAID is ibuprofen. So lactating mother with pain, ibuprofen is a very safe NSAID.
What can you give instead if they've got pain and inflammation? What can you give instead of the non-steroidal?
So if it is a arthritis pain, low-dose steroids are safe.
Excellent.
So Dr. Shwetal, can we use steroids during pregnancy and lactation?
Yes, steroid can be used during the pregnancy, but steroid has its own sets of side effects. Steroid prednisolone dose should be less than 20 milligram, and it should be at the minimum level, whatever is possible to control the disease. And so steroid should be tapered, and along with that, the other things like maternal blood pressure, blood sugar should be monitored. And in lactation, steroids are safe, that can be given.
So, Dr. Raja, are anti-TNF drugs like etanercept, adalimumab or infliximab safe during pregnancy and lactation? Any special precautions to consider?
We all know the anti-TNF drugs have revolutionized the management of rheumatoid arthritis and other rheumatological illness. See, they are safe during pregnancy. The safety data of anti-TNF drugs are good in pregnancy. The problem is, when you use it in the later part of the pregnancy, third trimester, there is a chance of anti-TNF drugs crossing the placenta and entering into the fetal bed. So when the child is born, after that, they have these drugs with them. So you cannot give live vaccines. So what the recommendation is that you try to stop this anti-TNF drugs before the third trimester. For every anti-TNF drug, there is a cutoff. Like etanercept, they asked to stop at 32 weeks. For infliximab, 20 weeks. Adalimumab at 28 weeks. So you stop these drugs. And third trimester, without these drugs, we manage. But if the patient's symptoms are so much that these drugs are needed during the later part of pregnancy also, it's okay, you can give. But after delivery, you should not give live vaccines for up to 6 months to the newborn. Because there is chance of, suppose the problem here is the BCG vaccine in India and in the abroad countries, it's rotavirus vaccine. So both are live vaccines, which has to be avoided. During lactation, there is no problem with anti-TNF drugs and they are safe to be given.
Well, as the anti-TNF revolutionized the treatment of rheumatoid, now we have the JAK kinase inhibitors which are new and they are oral medication and they seem to work excellently well. Well, what's the score during pregnancy and lactation, Dr. Sweta?
So for JAK inhibitors in pregnancy, they have to be stopped at least 2 weeks prior to the conception. And their safety data is not available in the lactation, so it has to be avoided during that time.
Thank you. Thank you. Yes. Now, one of the complications of lupus is lupus nephritis, and you see a patient who's got lupus nephritis, and the earliest signs would be proteinuria and macroscopic hematuria, etc. Now, what drugs can be used and what cannot be used? In particular, we are talking about cyclophosphamide, MMF, and rituximab. So, what's the score as far as that is concerned during pregnancy and lactation, Dr. Raja?
So, lupus nephritis, as we all know, during the induction phase, we have mainly two drugs, that is cyclophosphamide and mycophenolate mofetil. Ideally, the patient should not have become pregnant while the disease is active. So, if we see the patient beforehand, we would have advised them not to become pregnant because the disease has to be silent for at least 6 months. So, but if a patient has developed lupus nephritis, then mycophenolate mofetil, no, it cannot be given during pregnancy. Ideally, it has to be stopped 6 weeks before conception. Cyclophosphamide is also not recommended during pregnancy, but if there is a situation demands and there is a life-threatening or organ-threatening problem, cyclophosphamide can be given, but cyclophosphamide is known to be teratogenic. So other options in lupus nephritis are cyclosporin tacrolimus. Of late, tacrolimus has been used especially in class 5 lupus nephritis. It has got a good safety data in pregnancy, but you have to monitor maternal blood glucose, blood pressure, creatinine. So that is important. As far as maintenance, azathioprine is a safe drug during pregnancy for maintenance of lupus nephritis. So generally, avoid pregnancy when there is lupus nephritis. Ideally, patient should not have LN, active LN. So if that is the case, then these are the scenarios. And rituximab, yes, rituximab, but the guideline says that rituximab has to be stopped before consumption. But if again the situation demands that there is no other option, you have to give rituximab during pregnancy, you give. But like any other biological drug, you should delay live vaccine for the newborn up to 6 months of age.
So, Dr. Shwetal, which anticoagulation is safe during pregnancy and lactation?
So, if we talk about the anticoagulation, heparin is safe in both pregnancy and lactation, that can be given. Low molecular weight heparin also can be given. Warfarin has to be avoided, especially during the 6 to 12 weeks period, because there is a risk of warfarin fetopathy. So warfarin has to switch, and warfarin is safe during the lactation period. Then patient can be shifted back to warfarin.
Dr. Raja, like how to manage fibromyalgia during pregnancy and lactation?
See, management of fibromyalgia per se is a difficult scenario in pregnancy. Actually, when I looked at the literature, what I found out was that tricyclic antidepressants are very safe. So you can use amitriptyline. Amitriptyline is supposed to be the safest drug during pregnancy to manage fibromyalgia. So that is one thing. And what about pregabalin, gabapentin, a pregnant lady developing neuropathic pain? The guideline says that pregabalin, gabapentin, all can be used, provided if there is no other alternative options. And suppose a pregnant lady is depressed, again, or a lot of somatic component is there. Can we use fluoxetine, sertraline, selective serotonin reuptake inhibitors can be used. We can even use duloxetine, venlafaxine. But there are some case reports of neonatal depression syndrome, but they are not very common. So the point is that amitriptyline is a safe drug during pregnancy to manage this fibromyalgia symptoms. Of course, other drugs can be given if there is no other alternative option.
Well, this is the last question. A 32-year-old man with spondyloarthritis on sulfasalazine, worried about infertility. What counseling would you do?
Sulfasalazine is known to cause reversible azoospermia, but not in everybody. That is number one. And there are case reports which says that for some patients the azoospermia is not reversible also. There are some studies which is mentioned there also. But generally, because we see many ankylosing spondylitis patients about to be getting married, they start on sulfasalazine. Generally, we don't stop. If pregnancy is not occurred after 12 months of marriage, then we assume that sulfasalazine could be one of the reasons, and we try to stop sulfasalazine, but it's not a hard and fast rule. Generally, we don't stop sulfasalazine at the outset. But if after more than 1 year of marriage, still there is no pregnancy, then we can stop.
Thank you.
So any questions from the audience, if somebody I want to ask?
What about methotrexate for fathers? How long we have to when we have to stop methotrexate?
For methotrexate doesn't have need. There's nothing.
For methotrexate for
No,
fathers.
no. The guidelines clearly say that all drugs can be for a potential father, they can take.
Except cyclophosphamide.
Except cyclophosphamide.
But the father generally asks this question, and in clinical practice, we do not ask them to stop it.
Yes.
Yeah.
So with this we end the session. Anybody who wants to ask one?
Status in lactation.
Hydroxychloroquine, sulfasalazine, safe in lactation. But make sure that when you give a patient gets sulfasalazine, the newborn should not be a premature infant. They should not have G6PD deficiency. Other than that, these two, methotrexate and leflunomide, are contraindicated in lactation.
It's still, then the anti-TNFs are there.
So I think to sum up, like it is, whenever the first contact with the patient, when the first time the diagnosis is made, I think that time with the lady, because most of the patients are females, like rheumatic musculoskeletal diseases. So we have to at length discuss with them, see you are on these drugs, what is the, like once you get married, so you have to come back. Whenever you are planning your family way, if you are going to, at least come back and discuss everything with us.
Just I want to add only one thing. You should not use tramadol in the first trimester in peri-consumption. Ultracet, no. No, not in the first trimester. Ultracet is known to cause fetal abnormalities. So that is because we think tramadol is safe, no, because in that alone should not be used in the first
Tramadol
trimester.
is safe for the kidney and the other,
Yes,
but not in lactation and pregnancy.
About to become pregnant, peri-consumption period and first trimester, we don't give tramadol. That
So many of the rheumatologists now, they are just focusing on like dedicated like clinic for the for lactation and pregnancy, like whenever, so that they can at length discuss and spend time.
Thank you all very much for staying back. Thank you, Dr. Raja, Dr. Shweta, and Dr. Taylor.